Can you see my slides?
Yes, sir.
Yes, sir.
Oh.
Yes.
The participants you can see, including us.
Shraddha, Dr. Mantri sir would be joining us. Should we
Yes.
remind him once on
Yes,
message or?
heard him. Yeah, he will be joining shortly.
I think you can start.
Okay, so shall we start now?
Yes, please go ahead.
Yeah. Okay, so good morning, everyone. On behalf of Chellaram Diabetes Institute, I, Dr. Ashutosh, currently working as a consultant physician. Welcome everyone, including national and international participant, faculty, delegate, participant. So in this CME, we are going to discuss regarding the important aspects about the obesity and its management, which include both the medical and surgical management. So in this CME, we have actually two sessions, where the first session, in that we are going to discuss about the important or introductory aspects of obesity and dietary management and exercise management. Later, following which we will have a question and answer session of a brief period. And later, our other faculties will be going to discuss regarding the novel therapies and surgical management of the obesity. So moving further, let's start with our today obesity. Let's start with our CME regarding obesity management. So our first session will be by Dr. Anil Pandit, and he is a CMD of Chellaram Diabetes Institute. So over to you, Dr. Anil Pandit, sir.
Piyush, you will have to play the video.
Okay, sharing.
Yes.
Very good morning to all ladies and gentlemen who have eagerly joined us at Chellaram Diabetic Institute and Chellaram Hospital for Diabetic Care and Multispeciality. Today's CME is going to be on obesity management. All of you know that obesity has become a big burden on the society, and more number of cases are coming out because of this pandemic which is going on. Obesity is basically a non-communicable disease, and we all know it is a sort of a health hazard, and it keeps on, the number of cases keep on accumulating if we do not address to this problem right now and now onwards. Some of the figures, though I'm not a believer of the statistical jargons. Since 1995, the number of cases of obesity in the world has tripled and is almost 2.5 billion cases are there all over the world in the age group of above 18 years. And if you see in the childhood obesity, less than 5 years children, 39% of the world population, the child group of less than 5 years, they have got obesity. What we call them as chubby babies. Is obesity preventable? Yeah, if it can be managed at right time, and if we apply certain restrictions and constraints on our lifestyles and so on. There are many reasons for people becoming overweight as well as developing obesity. The reason may be physical, that in some cases they inherit some genes which prones them for obesity, and there may be psychological problems, especially in these days of pandemic. What we are having, that work from home, isolation, loneliness, and also tendency to binge on the fast food, which are full of saturated fatty acids and calories. And of course, last but not the least, is the environmental factors. Some peer pressures, sometimes the people don't exercise, and environment may be because of the people are fond of, as I said earlier also, fast food, junk food and so on, because it's easily available. At home environment, they don't have to cook, they just bring the food from outside and it is heated up and they eat. And there is virtually, they don't bother about the calorie intake, and of course the beverages, whatever they take, that also adds on to the calories. Obesity always comes with certain comorbidities. Maybe it is one of the major factor contributing towards the development of the type 2 diabetes. And secondly, they develop lots of musculoskeletal problems, especially osteoarthritis and so on. Type 2 diabetes, as I said, hypertension, ischemic heart disease, and so on. What are the adverse effects of overweight as well as the obesity? One is it reduces the self-esteem of the individual. He becomes a sort of it gives him a sort of inferiority complex whenever he is in the peer group. He or she, they lose their confidence in themselves, leads to the depression, loneliness, and so on. And all of them put together, they slowly get isolated from the mainstream society. That's why we have to address the weight gain as well as the obesity as early as possible. These can be done, as I said, obesity is a non-communicable disease, it is preventable, but it requires right up exercise, control on the diet, regular sleep, and less strain, stress, and so on. Today, we have got a galaxy of experts who are going to speak upon the obesity and how to overcome the weight gain and so on. These speakers are from the various fields. I will be followed by deliberation by Dr. Vedavati Purandare. She is our senior consultant physician, and she will be giving you a brief introduction on the obesity and how it can be managed. Next in line is Dr. Geeta Dharmati. She is our nutrition consultant at Chellaram Diabetes Institution, and she's an expert on obesity management as well as the weight loss management. Then we have got, as I said, we have to have regular exercise. What type of exercises? Cardio and non-cardio and so on. For that we have got Dr. Malhar Ganla. He is clinical obesity specialist from Pune. He will talk basically on the physical activities. And the next session we will have a real expert on obesity as well as the diabetes, our own chief endocrinologist Dr. Krishnan. He will be talking upon how to manage weight gain as well as the obesity by the medical management, the newer trends, the advantages and side effects and so on. Then obesity, sometimes if you cannot manage by medical therapies, we have to switch over to some surgical interventions. For that, to enlighten us, we have Dr. Neeraj Raite, the senior bariatric surgeon from Pune, and he will be telling about the interventions. Various interventions are there, bariatric surgeries, various types, gastric bypass and so on. Finally, we have got an expert from Washington, Dr. David Cummings. He is the director of the weight management system, University of Washington, and his passion is basically on weight loss and weight gain, a clinical perspective. Both weight loss, too much of weight loss is also not good, and too much of weight gain is also not good. What are these, adverse effects, or how they can be reduced? So it's a half-day session, and I sincerely hope all of you will enjoy this obesity management. The CME is basically to create awareness amongst everybody, and when you go home, you can talk to your other colleagues. You can follow whatever the doctors have, the experts have given you some inputs. You can share them with your patients so that the awareness is created. And as I said, lot of economic burden, obesity is an economic burden for any society. And I hope you all the best. Take care and be safe. Thank you.
Thank you, Dr. Anil Pandit, sir. So moving further, now we will have our next session by Dr. Vedavati Purandare on introductory aspects of obesity. Dr. Vedavati Purandare, so let me just share her CV. So she is a consultant physician and diabetologist at Chellaram Diabetes Institute, Pune, and she has done her MBBS and MD both from BJ Medical College, Pune. During her academic year, she has received many awards, including Dhirubhai Ambani Scholarship for academic performance. Also, she has presented in international conferences such as International Diabetes Federation Congress in Vancouver and at Spain, where she presented her work on renal disorders in diabetes. She also has a number of scientific publications in national as well as international medical journal. She was a regional faculty for advanced certificate course in prevention and management of diabetes and cardiovascular diseases. And as I said, she is going to talk on introductory aspect of obesity. Over to Dr. Vedavati Purandare, ma'am. Thank you.
Thank you so much, Dr. Ashutosh, and a very good morning to all the delegates, respected faculty members, and Dr. N.N. Mantri, sir, who is Maharashtra Medical Council observer for this meeting. And tomorrow we all are celebrating World Obesity Day, which is a day where we all have to come together and improve the awareness regarding obesity in the population. So we are meeting for a virtual CME on obesity management. We all know that obesity is one of the commonest global health concerns, and most difficult to manage health issue. And today we are very fortunate to have experts linked to various aspects of obesity treatment, starting from Dr. Geeta, Dr. Mallar, Dr. Unnikrishnan sir, Dr. Neeraj Raite, and we are extremely glad to have Professor Cummings, who is physician expert managing obesity. So now in next 20-25 minutes, we will see some basic clinical pointers which might help in our day-to-day clinical practice. So we all know that obesity is a chronic medical condition characterized by excess fat accumulation, which is detrimental to our health. And it is one of the leading causes of morbidity and mortality, with huge number of comorbidities associated with the weight gain. And when it comes to the deeper understanding of obesity, there is a huge gap. And today in this CME, we will get more answers to our questions on day-to-day clinical practice. And the global consensus and the recent data from many countries, we can find that over 650 million adults are obese and over 1.9 billion adults are overweight. So there is exponential rise in the obesity and ultimately various comorbidities linked with it. So we have to come together and spread awareness and reduce obesity prevalence. So obesity, we know that it is common in urban as well as rural population. In one of our studies where more than 29,000 subjects from rural India was studied, we can see here that as per the norms, BMI above 25, the obesity as per the Asian cutoffs, more than 25%, that is 26.4% adults were obese even in the rural India. So obesity is affecting urban as well as rural population. And currently in clinical practice, obesity is assessed by measuring body mass index, which is also called as Quetelet index. We all know it is weight in kg divided by height in meter squares. Internationally, we know that obesity is BMI above 30, but as per the Asian cutoffs, the obesity starts after BMI of 25. So these are the BMI cutoffs for normal weight, overweight, and obesity classes. And we all know that as the obesity increases, the risk of weight-related illnesses increases gradually. But only BMI should not be considered as obesity assessment because there are few limitations of BMI. Imagine a weightlifter. So he will be having more muscle mass, and we all know that muscles are heavier than fat. So muscular people often have healthy weight, though their BMI is in obesity group. So weightlifters may have BMI of 28, 29, but their muscle mass would be high. So we should not misdiagnose them as to have obesity because the fat may not be that high. And BMI and total fat mass alone might result in misclassification of individuals with normal weight, but they have central obesity. So total fat distribution as such, the BMI could be misleading in that sense. BMI is not reliable in certain situations like where the person has fluid retention, like kidney diseases, advanced liver disease, cardiac failure, where the body is retaining fluid. So that could be falsely high BMI. Even in pregnancy, it is not reliable. And few ethnic groups like Asians have much high risk of developing health problems at BMI even below 25. So these things we have to consider while classifying obesity, only considering BMI. So see this OPD summary. In our day-to-day busy practice, clinicians, we do see pulse and BP, and sometimes we just see weight. In this OPD summary, we have a 63-year-old gentleman. If we see his weight is 60 kg, height is 157, his BMI is 24. So if we just stop here, we miss counseling that subject regarding obesity, because when we see further, his waist circumference is 115 centimeters, his waist hip ratio is quite high, which indicates central obesity. So in busy practice, we clinicians have to take help of our paramedical staff, including nurses, or you can train your reception staff just to take these parameters quickly and then while counseling any patient, we need to emphasize on obesity, central obesity. So even if a patient comes for cough and expectoration, and if he is obese, the final take-home message for him should be, after we manage your cough, we need to plan your weight loss gradually. So when patient also goes home, he is thinking that I have to lose my weight, because in some population, obesity is not considered as disease. It is considered as a sign of prosperity. But we have to tell them that definitely action has to be taken. Even if your BMI is 24.5, the waist hip ratio is high, and we need to focus on that, because early diagnosis, early management will give us more chances of successful treatment and prevention of comorbidities. And in obesity, the treatment delayed, patient gains weight, the waist circumference increases. So treatment delayed is treatment denied, because ultimately patient will develop all the comorbidities like diabetes, hypertension, coronary artery disease. So treatment delayed early would be treatment denied, leading to worse outcomes. So these things we have to make sure. So from tomorrow, that is World Obesity Day, 11th October, we will make sure that in addition to BMI, we will see waist hip ratio and waist circumference also in all our patients. We know that visceral fat, which causes central obesity, is a significant threat to the cardiometabolic health and independent of overall obesity. And addition of few anthropometric indicators of central obesity to BMI is recommended by all the health organizations. We all know that visceral fat, which is fat in the abdomen, it is not the subcutaneous fat. The gold standard technique to measure the exact visceral fat is CT or MRI, but they are expensive. And in resource limited settings like India, we may not diagnose central obesity by doing CT and MRI in our population. So these are the anthropometric indicators which add to our knowledge. First is waist circumference, second is waist hip ratio, and third is waist to height ratio. And there are many studies which have shown that these measures are strongly associated with the risk of cardiovascular disease, cancer mortality, and it is independent of BMI. So even if BMI is not in the category of obesity, these parameters will help us. So first is waist circumference. According to Indian cutoffs, abnormal waist circumference is more than 90 centimeters in men and more than 80 centimeters in women. And the international cutoffs as per NCEP are 102 centimeters for men and 88 centimeters for women. So we have to know these figures and we have to tell these to our patients. Waist circumference ideally should be measured at the midpoint of inferior margin of the ribs and superior border of the iliac crest. This we have to tell our paramedical staff who is measuring the waist. It is not at the level of umbilicus. Then second indicator of central obesity is waist hip ratio. So we have to measure the waist circumference at the midpoint as we discussed. And then hip circumference should be measured around the widest portion of the buttocks. And the ratio of the waist and the hip circumference is measured, which is called as waist hip ratio. And more than 0.9 for men and more than 0.85 for women is abnormal. And we know that apple-shaped obesity and pear-shaped obesity. Apple-shaped obesity has more chances of morbidity, mortality, and more association with metabolic syndrome as compared to pear-shaped obesity. So which is the better indicator, waist circumference or waist hip ratio? So see this lady on the left side, her waist circumference is 72 centimeters, hip circumference is 95, her weight is 50 kg, her BMI is 22, and waist hip ratio is 0.76. After 5 to 6 years, this lady gained a lot of weight, and her weight, which was 50 kg, is now 90 kg, and there is increase in the waist circumference 95, but proportionately the hip circumference also increased. And when we see the waist hip ratio, it is 0.76. So this can be misleading. So definitely waist circumference is a better predictor of visceral fat than waist hip ratio. So in busy clinical practice, we can at least see waist circumference if we have less time to calculate waist hip ratio. Then third parameter is the waist to height ratio. So waist to height ratio is waist circumference divided by our height, and ideally our waist has to be less than the half of the height. So see this graph, a gentleman whose height is 150 centimeters, if his waist is less than half, that is less than 75 centimeters, will be in the green zone, that is less risk of cardiovascular disease. But if the person's whose height is 150 centimeter, if his waist is 100 centimeter, we can see here, which is more than the half of the waist circumference, the cardiovascular risk increases into the red zone. So waist to height ratio is the third parameter or third anthropometric indicator which tells us about the central obesity. So whichever is convenient in our clinical practice, we should implement this. And we can see here the waist strip ratio, waist to height ratio in females and in males. So around 0.5 is healthy, but if it increases, it indicates central obesity. Now we know that CT and MRI, they are the gold standard to see the visceral fat, but they are not easily available. They are expensive. In CT scan, the radiation exposure is a lot. So DEXA scan, which is ideally used for bone density, it is also used to estimate the visceral fat. DEXA scan uses X-ray technology to determine the distribution of lean muscle, fat, water, bone. It works by passing two safe and remember very low density X-ray beams through the tissues of the body. So the radiation exposure is much less as compared to CT scan, and fat mass divided by total mass into 100 is fat percent. So DEXA scan can give us a good indicator of visceral obesity and fat mass percent. Now we saw that BMI and then these three parameters, waist circumference, waist strip ratio and waist to height ratio, these are used for assessment of obesity. Now discussing pathogenesis of obesity in short, we know that there are multiple factors which contribute to obesity. Environmental factors, we know that energy intake, that is calorie consumption, and energy expenditure, calories burn out. When the energy intake is much more than the energy expenditure, the fat gain occurs. Then there are various genetic factors which are involved in pathogenesis of obesity. Then behavioral factors, we see that overeating, reduced physical activity, lot of stress is also linked with pathogenesis of obesity. And then there are various medical or endocrine causes which we have to rule out in patients who have morbid obesity, like Cushing's syndrome, hypothyroidism, insulinoma. So these are the various factors when we see patients with obesity. So energy intake, when a person is eating more calories and the energy expenditure is less as compared to the energy intake, then excess adipose tissue forms in the body. The energy expenditure, we know that it is resting energy expenditure, then physical activity, exercise on regular basis, and NEAT, which is non-exercise activity thermogenesis. So many patients who are obese, they say that they have done their exercise in the morning hours, 6 to 7 a.m. and all during the day they are sitting. So we have to counsel them that in between also they have to do some activity, they have to walk in between, which also contributes to non-exercise activity thermogenesis and which improves their basal metabolic rate and energy expenditure. It is not just energy intake and energy expenditure, but we know that there are various hormones which play their role in pathogenesis of obesity. So there is neuroendocrine gut axis. We know that there are hormones which are leptins, ghrelins, cholecystokinins. These hormones play an important role in weight balance. Adipose tissue or the fat is not just a cosmetic problem, but we all know that it is storehouse of inflammation because it produces a lot of inflammatory markers which are not good for us, which lead to accelerated atherosclerosis, which lead to insulin resistance, and there are various hormones which contribute to obesity also. So adipose tissue produces leptin. We all know that leptin is a hormone which controls our weight. In a simple language, leptin is called as personal trainer, because when we eat more, adipose tissue secretes leptin, and this leptin signals to our brain that we should eat less. So ultimately it stimulates satiety center and we eat less. So this guides our appetite. But in very obese patients, there is leptin resistance. So the action of leptin is less. There are other various hormones which the time is less, so we cannot go into details. Brain, a very important organ which plays a role in weight balance, and we know that hypothalamus and there are other centers in the brain which also release and responds to various hormones and neurotransmitters responsible for weight control. Like when the gut or the stomach and intestine secretes a hormone which is called as ghrelin. Ghrelin is also called as hunger hormone, because ghrelin increases our appetite, and person who has more ghrelin levels in the blood eats more, and hence these hormones are responsible for weight balance and obesity. We all know that GLP-1 is good hormone for controlling weight, and there are theories of gut microbes also, where the gut microbiota transfer helps in weight control. Gut microbe theory raises possibility of manipulating the gut microbiota, which could facilitate weight loss or prevent obesity in humans. So if a gut microbiome is taken from the lean person and transferred to an obese person, then the chances that this obese person becomes leaner increases. So this is under trial and studies, but animal model studies have given us good ray of hope here, because when obese mice were, the gut flora was transferred from a lean mice, that obese mice lost weight. So this gut microbiota and the gut flora transfer therapy might be a future in obesity treatment. Now, is there a energy fat set point? So if a person has a set point, so if imagine that my weight is 70 kg, and if I try and lose it to 65 kg, so if my BMI decreases, my energy expenditure also decreases and my energy intake increases. So my body will always try to be at that set point. And if I gain weight, which if my BMI increases, my energy expenditure also increases and my energy intake goes down. So there are studies which show that there is a set point for our body weight. And Dr. Neeraj would be telling us that with bariatric surgery, whether this set point decreases, which might help in controlling weight balance for long term. Now, after discussing the pathogenesis of obesity in short, we know that complications of obesity are, I would say, infinite. There are metabolic complications, n numbers of metabolic complications. There are mechanical complications. Then there are psychological complications. So in addition to diet consultant, exercise consultant, physicians, endocrinologists, bariatric surgeons, the role of counselors and psychiatrists also come into play when persons are morbidly obese. And in one of our studies, when we studied obesity and complication, when we saw new onset diabetes and hypertension in the population of about 29,000, when we see from the left column, we see the BMI increasing number, and we can see here in them the newly diagnosed hypertension, the percent increased as the BMI increased. So as the weight increases, the new onset hypertension increases. Similarly, newly diagnosed diabetes also, when the BMI was less, it was 8.2%, which gradually increased. So this slide clearly shows that as we gain weight, the chances of hypertension and obesity, they increase. Now, this was one study published which recruited more than 9,000 participants, and the patients were divided into 4 quadrants with increasing the weight. So when we see the fat mass percent in men and women, the fat mass increased from 23 to 27 to more than 27, and quadrant 4 it is higher. So at the fat mass increased, the total mortality increased. So in the 4th quarter, we can see that as the fat is more, the mortality is high. So these are the factors. We know the evidence is there. Obesity and mortality is more. So these are the things we have to tell our patients also repeatedly and counsel and motivate them for gradual weight loss and maintain their weight. So this slide shows on the x-axis there is BMI, and on the left axis the mortality ratio. And we can see here that if the BMI is 20 to 25, the mortality ratio is low. 25 to 30, it is okay. But after the BMI of 30, the mortality increases, and there is sharp increase in the mortality after the BMI of 35. So we can see here that mortality increases after 35, but we have to also see here that after below BMI 20, the mortality also increases. So it has to be, the weight has to be in the healthy way. It should not be very high, it should not be very low. Then when a person comes to us with obesity, we have to take a detailed medical history regarding weight, how the weight increased. We have to ask patient that in last 5 years, how much was your minimum weight, how much was your maximum weight, and we have to track patient's weight, whether patient is on the weight loss track or weight gain track. Then also ask about the comorbidities like type 2 diabetes, hypertension, cardiovascular disease, and we have to check whether patients are taking medications which are contributing to weight gain. In diabetes, we have to see whether patients are on sulfonylureas, whether patients are taking insulin, whether patients are on pioglitazone. In COVID era, we have to see whether patients are on steroids or history of recent steroid intake, which might contribute to weight gain. Then this is very important aspect. We have to check the history of obstructive sleep apnea in the sense of snoring at night, daytime dozing, feeling extremely tired in spite of following lifestyle measures, patient not able to lose weight, morbidly obese patients, because correcting sleep apnea also helps in weight loss. Then we have to see history of weight gain, family history of obesity to see for some genetic clue. Then ask patient about dietary and exercise habits and really go into details of it, because obese patients, we don't have to judge them. We don't have to judge them, and we don't have to just keep it in our mind that they must be eating more and not doing exercise. But if they are really following balanced hypocaloric diet, really exercising well and still not able to lose weight, we have to find out some other cause and treat accordingly. Then we have to see pattern of weight changes, history of weight loss attempts, then detailed physical examination, blood pressure assessment, relevant blood investigations related to obesity, including serum cortisol, in glucose levels, TSH, and then management of obesity. We have expert Dr. Geeta and Dr. Malhar to guide us about the lifestyle interventions, but a sustainable diet plan which is balanced with less calories, and our exercise plan really helps patients to lose weight. Pharmacotherapy for some patients we can consider, but we all know, clinicians practicing obesity, that the pharmacotherapy is not used all over, and it is not very safe and effective option. Effect can be there, but not all medicines are safe. Then some medical devices, Dr. Neeraj is here, and regarding bariatric surgery, we will hear from him. These are the drugs, just in short, I'll mention. So Orlistat, we know that it is lipase inhibitor. It leads to some weight loss, but steatorrhea and chronic malabsorption is a problem. Capsule Orlistat 120 milligram can be given. Lorcaserin is a serotonin agonist, and it also has got side effects in the form of valvulopathy. Liraglutide, we all know, it is injectable form, leads to GI intolerance. Oral semaglutide is on the horizon, so we have hopes from it. Penteramine topiramate also is used for weight loss, and rather it is the strongest player in the group, which causes good amount of weight loss. But again, the suicidal ideations and other side effects we have to monitor. Naltrexone bupropion also is used, but we can see here that suicidal and behavioral changes are there, and nausea, vomiting is also seen with naltrexone bupropion. Then there are medical devices for weight management, including intragastric balloons, which are available in our country. Electrical stimulation system and gastric emptying system are not available yet. So we have seen these forms of therapies, but definitely long-term therapy is lifestyle modification. And in addition, to all these aspects, we have to counsel patients that they have to try and lose weight. And definitely patients, when counseled and motivated, they will follow the track, and which will help them to achieve their weight loss goals and maintain it. Thank you so much for patient listening. And I am eager to listen to speakers coming in the next session. Thank you so much.
Okay, thank you, Dr. Vedavati Purandare, on your excellent presentation on introductory aspects of obesity. Now we will be moving further, and our next session will be by Dr. Geeta. So Dr. Geeta Dharmati is a diet consultant at Pune and is a director, founder of Geeta NutriHill Nutrition Consultancy. She is a chief nutrigenomic counselor at Gene Support and chief bariatric nutritionist at Diabetic Obesity Surgical Solution, which is a DOS. Also, she is an executive member at Indian Dietetic Association and associate professor and PhD guide in nutrition at Tilak Maharashtra Vidyapeeth. She is a guest faculty at CCIH Ayush Department at Pune University, and her area of expertise are critical care, bariatric, nutrigenomics, wellness, and lifestyle management. Dr. Geeta Dharmati will be speaking on the nutritional approach for the weight loss. Over to you, Dr. Geeta, ma'am. Thank you.
Thank you, Dr. Ashutosh. It's really wonderful to be amongst all of you in this auspicious season of Navaratra, and wishing each one of us a very happy Navaratra and an auspicious blessings, so that we have a healthy life and wellness always. In these past 2 years, we've been fighting with a lot of health challenges, right from anxiety to mental, emotional health challenges to our wellness and prevention. And this CME definitely tries to tell us that prevention and wellness is the way forward for our health. How wonderfully put up by Dr. Vedavati Purandare in a very simple 20 minutes, that the introduction to the overall obesity approach. And in that, she continuously highlighted the importance of lifestyle management. And I'm glad to be amongst all of you to talk about nutrition approaches, because that's my area of expertise. In this era of a lot of media exposure and lot of WhatsApp universities ideas, we are here to learn authentic way of understanding how a nutrition support will help obesity management. Obesity is not new, friends. We all know that it is a disease which is now rising in urban, rural Indian population. The environmental challenges are more. There is genetical aspect, but I'm sure 75 to 90% of us are fighting with environment. The obesogenic environment, and especially in the past 2 years, my experience says, I have patients who come to me. It is like before lockdown and after lockdown. And they say, in this lockdown, average weight gain each one of us are facing is 2 to 5 kgs. Whom do we blame? Because the cutoffs of BMI have been 22.9, and the participants here, I think if you calculate your BMI and the criteria which was told to us by Dr. Vedavati, how many of us fit into those criteria is something we need to understand, because we are all here who practice health, who practice wellness and prevention. The BMI, the waist circumference, the waist to height ratio, I think we should be doing the walk the talk. And the next speaker, Mallar, he'll tell us what his fat percentage is. And I'm always awestruck when he says that how, because he practices exercise physiology and he walks the talk. So why not we become a torchbearer and understand the nuances, because the challenge which we are fighting today with obesity is energy balance. And I'm sure all of you agree with me. End of the day, maybe it's a medical management, interventional management, a nutrition management, and exercise management. It's all about addressing the calorie balance, the energy balance, the metabolism, the age, the hormones. But we are here to learn that where can we work on creating a hypocaloric environment in an obesity scenario. Food gives me energy, and that is why food has a lot of interest in this obesity industry, where every day something new comes up saying that this helps in weight loss. If it was so easy, I think we wouldn't have been here talking and discussing about a half-day long virtual weight loss therapy. There are many causes in obesity, and I'm sure you'll agree that each one of the clinician tells me that 70 to 80% is nutrition management. If we learn to handle our nutrition, I think we will be way away from this pandemic. And this nutrition management, all of us know, is not very simple. It is not that do's and don'ts in diets. It is not eating. It is not looking at your diet charts, which is copy pasted or which is being given by any kind of a dietitian or a gym management manager, which tells you that just follow this. The major challenge is understanding an individual approach towards it and a scientific approach towards how I can lose weight. Because if you ask any patient, how much time did you take to gain weight? For example, in this pandemic, each one of us have, when we talk to the client or a patient, he says that this pandemic, I've gained 2 minimum or 6 to 8 maximum. 2 years is the time our body took to gain weight so much. Why are we expecting a quick fixes here? Because in a lifestyle management, adherence and sustenance is something we should look forward. The goal of any therapy in obesity, all of us agree, is energy deficit. And first target, depending on the BMI, is how can I make the first 10% weight loss? Morbid obesity, 10% means a lot of weight. But a person who is just BMI of overweight category 26 to 28, it is 10% weight loss, which means 5 to 8 kgs. The first step in a scientific approach is giving the patient or the client a minimum deficit of 500 to 1,000 calories every day. Because all of us know 7,700 kilocalorie deficit or surplus gives you minus and plus of your 1 kg weight. Your body needs to go in 7,700 kilocalories deficit to make you lose 1 kg. So if I am comfortably able to go in a 500,000 calorie deficit, depending upon my lifestyle, my activity, my challenges with my obesity, I think that is very, very personalized. So let's expect minimum 500 to 1 kg. I tell my patients, do not rush hard. Minimum 2 kgs, maximum 4 kgs. But maintain the lost weight, because the whole challenge is give your body a calorie deficit environment. While I give my body this calorie deficit environment, I look at a good nutrition support. Nourish should be the mantra. Hypocaloric diet should not be giving me that, because anything going deficit or surplus is a stress to my body. Eating less or eating more. Either way, I'm giving my body some kind of a plus and minus energy challenges. So if I'm taking my body to a calorie deficit, I need to keep nourishment in my mind. And the nourishment goes with the macros and micros of my calorie calculation. For example, let's take a weight of morbid pre-obese status of 27 to 29 BMI. And I want that person to lose 10 to 15 kgs, especially the waist circumference. Because the last 10, 15 kgs, we are struggling with the visceral fat, the abdominal obesity. So the management is very simple, friends. We say, calculate your ideal body weight. In a day-to-day practice, Broca's index is a very easy way of calculation. It says height in centimeters minus 105 for females and height in centimeters minus 100 for males. So once I understand the ideal body weight, for example, for a male of 175 centimeter height, the weight is 75 kgs. I have to make him lose weight, right? So I either multiply the 75 ideal body weight with 25 to 30 calories, because every kg needs minimum for a sedentary lifestyle 25. This is rule of thumb. This is very easy. You have a lot of formulas to calculate. But simple way, on a day-to-day basis, we can always say that ideal body weight multiplied by 25 to 30 calories, or the present body weight, a 90 kg into 20 calories. So that gives me an 1800 kilocalorie. And this is quite significant. 1800 is quite a bit of calorie for a daily intake. If I can analyze, my patient can take himself to more calorie deficit after listening to his appetite, his satiety, his challenges with intake, the environment. I can play with 500 to 1000 calorie deficit per day, but that is very, very subjective. Once I give a calorie control, then I do my PCF, that is the protein, carbohydrates, and fat from the calories which I've calculated. Maybe I've said that I'll give you 1500 calories or a 1200 calories, depend on the patient how he's trying to look at his deficit. A very motivated, a very good willpower person can say, I can go for 12 to 1500 calories. Whatever the deficit calorie I calculate, my goal is 20% of that calories as proteins. So out of 1500, my first goal is I should not make him lose muscles as he loses weight. So 20%, more than taking for 1 to 1.2 gram per kg ideal body weight, that's one way, or 20% of the protein from the existing calorie intake. 30 to 35% is my fat, a good fat. And then 40 to 50% is my carbs. That's my first step of looking at obesity management, where I nourish, I keep the macros of my diet as priority protein and non-protein calories. And then I start looking at how much calorie deficit can I give to the patient. Because it is not easy. One size doesn't fit all. Same formula may not be applied for all. The whole goal is make the patient lose fat, as wonderfully explained by Dr. Vedavati, that the goal is not BMI correction. Simultaneously, the waist correction is the goal. Because for a dietitian or a lifestyle expert, metabolism is the first step. You can make the patient lose weight by eating less. Any hypocaloric diet, and sick patient, ill patient also loses weight. But the goal is lose fat, improve the metabolism, because your metabolism drives your 60 to 70% of your calories. The rest 30% is what I have in my hand to calculate. Fix the metabolism, especially in adolescence, in puberty area, where you have very high fat to muscle ratio. Explain, counsel about the metabolism correction. No quick fixes there. Just saying that so much of weight loss doesn't make sense. How much of fat loss and how much of metabolism correction is, I think, the way forward to talk about metabolism and obesity management. The whole challenge is losing the weight and maintaining it. To maintain it, you should right from day one start looking at how do I put a good muscle fat ratio. The goal is only fat loss. And I think if we start looking weight loss in such a sustainable and a long-term management with good counseling, because end of the day, convincing the patient that this is the right way is something which all of us have a greater challenge. And I think a lifestyle expert, a dietitian, it should be in such a position that she does a good job of giving a good overall patient education. Because telling the patient what a 1200, 1500 kilocalorie hypocaloric diet is for that patient is very, very important. Calculate the calories in front of the patient to explain him what an energy deficit means and what is a 1200 kilocalorie will look like in his diet. Manipulate the diet. Suppose he says, I have 4 cups of tea. I would say, can you have half cup 4 times a day? That will cut down my calories by 100 calories, which I think will be a help to our hypocaloric support. If he says, I want to eat 1 roti, my satisfaction comes with 1 roti, I would say, can you start with a protein and a fiber and see your satiety, how much it is by the time you reach 1 roti? So gauge, understand, slowly try to work, because the goal is education and sustainability and adaptation. Train the patient or the client to stick or adhere to whatever behavior modification we are trying to work on. And that is why the 3 strategies of weight loss: calories, that is the energy, count, explain, educate; portions, very easy to work towards your health goals; and the structure of the meals. Because end of the day, we are trying to make the patient work on his behavior, because I'm sure all of you will agree with me that most of the weight management and obesity cases are related to behavior modification. We all understand where we stand, but we are not able to work on it. And the research also tells us that first 6 months of treatment, even if you lose for 8 to 10% of weight loss, but adapting to a behavior management, maybe a portion control, maybe an exercise discipline, hydration discipline, circadian rhythm. Let's identify what is the root cause of weight gain. And if I'm able to work on the root cause by changing the behavior management, I think that is the first step or the base towards a good nutrition goal. Because the patient or the client will try to be there for some time, because he's got adapted to that particular style of eating, that time of eating, portion control. The minute we start thinking quick fixes and comparing the weight with somebody else and trying to promote our weight loss theories by saying so much in so many days or so much, and he and she has lost, then why can't I? And then we start getting carried away to a lot of fad diets. Few areas I want to explain where a nutrition support does work, but it is you and me as an expert to understand what to apply in a particular patient. So there are diet pills where it says that you can eat this, because the whole goal of any pill or any, this is about non-medical management, where it just gives you a satiety. It may be fiber, it may be some kind of Garcinia cambogia, which helps you to feel full. End of the day, you should know that everything helps me to eat less. Special food combinations, liquid diets, meal replacements, they all exchange your calorie intake. Few nutrition approaches which you will be interested in understanding, because there's a lot of confusion. What I discussed till now was a very sensible and a slow and an easy effort to work on a patient's, on a client's weight management. But the market is flooded, or the researchers are also there to tell us that which diet works, which diet doesn't work. Let's understand that in an Indian scenario. First, low fat. There was a decade, an era where the fat was a culprit, a villain. Today we say whatever it is, the fat needs to be 25 to 30% of your total calories. Total calories of the calculated. If you calculate for 1200 kilocalorie diet or 1500, mind it, your visible fat comes only to 2 teaspoons per day. Because in a 1000 calorie diet, if I have a 30% of my fat, my total fat comes to around 50 grams. Out of that, invisible fat is a good chunk. And half is invisible and half is visible fat. So my fat at the end comes to 2 to 3 teaspoons. So it's a calorie reduction and then the fat, but I think 25 to 30 is a good way of looking at fat control. But that, because you can't eat more fat, that's why keto diets are in vogue. People enjoy working towards fat as a source of energy, because satiety is very good and intake is limited. We can't eat oil and ghee only. We have to eat it from something. And if I eat a cube of cheese, ask yourself, a cube of cheese and then a slice of toast and a cheese sandwich. I can eat 4 slices of bread if I eat a cheese sandwich. If I eat a cube of cheese first and then a slice of toast, my calorie shrinks. I'm eating the same amount of fat. But this is almost 450 calories, and this is 1 slice of toast is 250 calories. So what is a low fat? I think we all should try to highlight and start looking at that fat contribution 25 to 30 minimum, because that is an allowed composition of macros which help us to work on good fats, because we all know fat is anti-inflammatory food, especially a good profile of MUFA, PUFA, SFA. This is not the forum to talk more in detail of fat, but yes, a good fat composition which comprises of half of your fat of your total calories as invisible or MUFA fat. The second approach, what we just discussed, the calorie deficit. 0.5 to 1 kg, slow, steady, adaptation, adherence. I think this is a better way to go at. The next nutrition support which we can think about is Atkins diet. Professor Atkins formulated this diet where 40% of the calories came from proteins, 20 from carbohydrates, and 40 from fat. Definitely, when the carbohydrates reduced to 20%, the insulin resistance improved. Satiety was better because protein is thermogenic food. But when it came to an Indian scenario like us, what 40% protein you can give? In a 1300-1500 calorie diet, my 40% protein will become 80 to 100. A bowl of dal is such a satiating food that I can't put too much of protein in a vegetarian diet because I can't eat so much. In fact, I'll have an IBS if I have too much of protein and increase amount of phytates to hamper my micronutrient absorption. Not a long-term sustainable, but yes, the good point is I lose weight because I control my calories and my appetite is suppressed because of the proteins and the fat in my diet. But the intake of protein is always challenging. I calculate for 1200, my patient or client can eat only 800 because he can't eat so much of protein and fat in the diet. Ketogenic, a well-famous diet, most of us follow. A very high fat diet and a very minimum, but it's almost similar to Atkins diet. But a very challenging diet, a no carb diet, I do not believe in because carbohydrates are the major source of energy. And using fat as a source of energy is accepted here. But I think putting too much of protein, too much of fat, I'm putting a lot of inflammatory responses in my body. I am not giving adequate fiber. I'm worried about my gut flora. I'm worried about my antioxidants in the diet. So I don't think this is a very great way to go ahead in balancing nutrition. I need carbohydrates. I need good carbohydrates. So I would not be looking, because the only good thing I find in ketogenic diet is it helps me to eat less. It's a hypocaloric support because it is high, very, very satiating. Because all of us know fat has a very delayed gastric emptying. I eat a complete fat meal. I always say basundi khao or kheer khao. If you eat a basundi, it's such a high fat meal, you feel I've eaten a heavy meal, which doesn't happen with kheer. What changes in these two is only the fat content. Because fat has a delayed gastric emptying, and that's course in the diets which have 40% of food as 40. But I think 40% is not a good idea. I add a lot of wrong fats in my diet, which definitely can lead to atherogenicis and other complications of vascular health. Vegan diet, mostly promoted. It's a good way because I control my good fats here. There's a lot of MUFA in my diet. There's a lot of fiber and antioxidants. It controls my diet because I'm able to eat good fiber in my diet. I improve my gut flora because I'm giving a very good prebiotic support. But I don't know whether I'll be taking care of B12 and proteins. My supplements are an important part of it. I may be adding too much of fiber, which may irritate my bowel. Again, it's very personalized. People who would like to go for vegan diet has a good option, but I think balancing of few nutrients, which is minusing in their diet, should be looked at. A zone diet is a very good diet where 40-30-30 carbohydrate, protein and fat ratio is there. I think this is a very good way of looking at it. If you calculate your calories, 40 from carbs, 30 from protein and fat, I think it has a very good support of nutrition, insulin resistance, and definitely a hypocaloric way of looking at your weight management. Intermittent fasting, yes, it's a good way of looking at it. The whole challenge is avoid food focus, maintain the glycemic load of the meal, see to it that you are fasting, but you are nourished at the same time. It doesn't mean the OMAD diets or 1 meal a day diet or an intermittent fasting diet or a time restricted diet doesn't mean that you have to eat large meals. It spoils your appetite. I'm sure Dr. Neeraj would like to highlight on the portions of the food which I'm eating. If I want to follow an intermittent fasting, it's a very easy way. Start with a fruit, then with a salad, then with a protein, and then with a carb. Follow these aspects. I think you'll be controlling your appetite, your calories, and definitely the science supports intermittent fasting that with after 12 to 14 hours, body looks at fat as a source of energy, but mind the nutrition and the balancing of nutrients to give you the best result and stick to it for life. End of the day, you're adapting to a particular eating pattern and you want to be there. You can't do anything for a short duration and then just look at it as weight loss management therapy. Weight Watchers is conscious eating, intuitive eating, mindful eating. I think this is what the Weight Watchers is. And I think that takes off your 15-20% of weight if you're really mindful of what you're eating. End of the day, I'm looking at personalized nutrition, and I believe in personalized nutrition. If I know what applies to my patient, it helps. It starts looking at the approaches towards my meal as what suits my client. A meal replacement, the patient is not able to work on hypocaloric diet, a very low calories for some days, a glycemic load, some kind of a manipulation in the diet. But educating patient about portions, size of their stomach, their intake, with simple techniques like hands. The portion can be very well explained. The size of the stomach, the size of the cup, grains, proteins, oil, sugar, chapati. This is so wonderful that your patient can take a lot of take-backs. The patient should give 30 minutes to the dietitian counseling, where the dietitian should actually sit in the patient's chair and talk to the patient about behavior management, do's and don'ts, which suits the patient, not which is generalized. Last way of looking at a newer technique of nutrition management is genomics. 75 to 80% is what we just spoke of. We can't ignore the 20% of genetics or molecular biology behind the scene. You have a lot of omics technology coming up to help you learn your preventable or epigenetic way of applying to your genomics. At whatever level I can apply, at a protein level, at a metabolic level, or at a transcription level. Through the human genomic study, which was a revolution study for us to learn about genes, few genes have been identified which contribute to your weight gain, your snacking habits, your abdominal obesity. And if I learn those genes, maybe I have a more accurate way of approach towards lifestyle management. Finally, this is also a tool which will help me to work towards the patient goals, but more into a personalized and precision manner. So I think we are now entering into a personalized and precision way of looking at individual. One size doesn't fit all. But the goal, friends, is to look at adherence and adaptation. It takes time to change. It is not overnight. And I think that's the role of a dietitian and an exercise physiologist and a psychologist to be in the team, to give assurance and motivation to your patient and give a plan which suits that patient. And I think whatever today we've discussed is something more about educating, learning. End of the day, what suits is very, very personalized. So thank you very much for giving me this opportunity to be amongst you on this August day and talk about nutrition support in obesity. Thank you so much, Dr. Ashutosh. Over to you.
Thank you, Geeta ma'am, for your beautiful presentation on nutritional approach for weight loss, where you have excellently presented the very important role of a diet in management of obesity and weight loss. Now moving further, our next session will be by Dr. Malhar Ganla, who is a clinical obesity specialist in Pune and will be talking on the physical activity. But before starting his session, I would request all the participants, if they have any question to our faculty who have presented till now, including Dr. Vedavati Purandare, Dr. Geeta ma'am, and also Dr. Malhar Ganla sir, who will be presenting on the physical exercise. So if you have any question from this faculty, kindly mention in a chat box. And if it's directed to particular faculty, please mention their name as well. As after the session by Dr. Malhar sir, we will be having a brief session of a question and answer for 5 to 10 minutes. And where our faculty will help you to solve your doubt regarding obesity. Now, Now let's start our session by Dr. Malhar Ganla, who, as I said, is a clinical obesity specialist in Pune, and he will be talking on the physical activity. Dr. Malhar is currently working as a Chief Innovation Officer at Freedom from Diabetes, and his primary area of interest is in child and adult obesity, diabetes. He has completed his postgraduate in sport and exercise science from New Zealand, and also he has a diploma in exercise psychology and exercise physiology from UK. He is also a bachelor in dental surgery, and he is a certified triathlon coach as well. So over to you, Dr. Mallar sir, and thank you.
Thank you, Dr. Ashutosh, to the management team. Thanks so much for having me. It's a pleasure to have a chance to talk about exercise for a change. Geeta, thanks for the compliment, but my fat percent is only equal to my percentage of knowledge compared to you. So it's all single digits. So here we go. Okay, let me just get this thing started. Yeah. So if we have to talk about exercise in obesity, it's one of the most underutilized tools in obesity management. I'm not going to purely talk about the details about exercise. We'll get a little more into the practical aspects of it. Both speakers before me have covered a lot of etiological aspects of obesity, so I won't get into that. We'll talk about a systematic approach to exercise prescription. It's understood that diet is always going to be the 80% factor, which is what causes it in the first place. But from an exercise perspective, the role of exercise is little different than what most of us imagine. The irony of exercise in our country, you go anywhere in our country, anybody will tell you walk for 45 minutes and do some yoga or exercise ho gaya. That is exercise in our country. We have reduced it to a bit of a joke. This is a myth that this is exercise. This is not an exercise concept at all. This is an activity. Okay, this is just being active. And considering 90% of obesity is non-syndromic, which means there is no particular pathology beyond it, except being upper middle class and suffering from what is called affluenza. So most of the diabetics we treat are simply affluenza driven. It's just a disease of a particular economic strata. When you cost a certain income, you will start eating out twice a week. It is the burden of affluence. There's nothing else to it. And we can keep drawing a lot of, colorful rhetorics around it. At the end of the day, it's a burden of a booming economy. It's going to happen. It happened in the US. It's going to happen here. It's happened in all developed countries. And the pace at which we are developing, it's going to be there, and it's a mainstay now. So my guide in New Zealand actually told me 10 years ago, I just wanted to do my MS in Ironman triathlon. I wanted to specialize in that. He said, nothing doing. You are way too academically oriented to be another coach. You're going to do your MS in obesity. And he turned out to be right. He forced me to do child obesity, which he said the less children that are obese, the less adults will be obese in the future. And he had a point. The tragedy is this is what most parents do. And if this is what we are going to set examples, this is what the next generation is going to do. What are you going to learn today? You're going to learn a little bit about the physiologic and the psychological role of exercise. It has a dual role. Its role is not calorie negative. Its role is not expending calories. It's not that transactional. Physiological role can't be, मैंने थोड़ा exercise किया, अभी मैं खा सकता हूँ. I did some exercise so I can eat. That's too transactional. We call it vyavaharik in our local terms, which means it's all a business. CICO, calorie in, calorie out. No, none of that business. What are the pitfalls of exercise in obesity management? So exercise has it's a double-edged sword, and I'll show you why. In obesity management, exercise has to play a very, very small role and a very specific role. What is the interplay? When does exercise come? When does diet come? When does diet make a comeback? When does exercise take a backseat? This interplay, it has to keep changing roles. It cannot be constant. More importantly, what is your role? As a doctor, what is the role? So till now, weight loss was the domain of gym trainers, of dietitians. The captaincy was always being shifted. Now that doctors are beginning to see more and more pathology as a result of diabetes, we see enough comorbidities. So naturally, it's now become that the doctor is going to become one of the key stakeholders in this. But what does he do? when he's not trained in dietetics, he's not trained in exercise, finally what happens is he ends up limiting his role to diagnosis. Now, diagnosis is not rocket science in obesity unless there is something specific in insulin resistance or some pathology lab marker. The obesity is very clinically visible. You stand in front of a mirror, a patient, you can tell he's obese. It's not very difficult to diagnose unless there is some pathological thing at play. And as Geeta ma'am eloquently said, it may even be a genomic thing. But that's a secondary story. Primarily, as a doctor, what is your role? So it's a bit confusing, right? This is what we see every day now. We didn't see these when we were growing up in the 80s and the 90s. This has become commonplace. 120 kgs is the new normal now for obesity. Earlier, it was 80 to 100. That 20% inflation has just happened. It's called an obesity creep. It has crept up on our generation. So children today who are in their teenage weigh exactly what we are weighing in our 40s. By the time they get to 40, they're going to be 40 kgs heavier than us with compound interest of the weight. So we're going to see an incredible inflation of weight in the next 20, 25 years. The problem is a lot of these are coming with certain specific lab markers, which you need to not analyze in every patient. But if you tell this patient to lose weight, he had low sperm count, he had very low testosterone. I think it was in the double digits or at the most in the low hundreds. He's not going to lose weight. But he was a smiling, happy-go-lucky IT professional making good money, happily married, ready to adopt. Now, if I get after him, lose weight, he doesn't want to lose weight. He may need to lose weight, but he's what I used to call him fat fit. And he's fat happy. The guy goes to the gym. The guy does everything. He's happy. But I want him to lose weight. Why? Because for me, he's a statistic. I keep looking at his BMI. No? His BMI must be well near 40. It doesn't matter. I jokingly told him on the first day, I said, forget about the BMI. Just go increase your height. Your BMI will come down on your own. We had a good laugh about it. He's lost 5-10 kgs, but that's it. There need not be numerical intervention all the time because exercise depends on a person's alignment. It is above the neck. It is not below the neck. We tend to treat everybody below the neck. There is a huge above the neck component here. And if a patient is happy, aligned, ready to learn, you need to be very responsible with the advice that you give. Okay? The physiologic role of exercise is very simplistic. It is mitochondrial activation. The neuromuscular junctions just have to activate. That directly causes an improved BMR. It need not be very, very complex. The more you move, the more there's activation, the BMR improves. That's it. There's less chance of and better recovery from injury. The most important role of exercise is recovery, because with aging, there will be injury, there will be incidents. The only thing that prepares the body for that kind of adversity is exercise, because you have trained it to handle adversity. You have trained it. What happens when you drop a 10 kg dumbbell, you bend down, you pick it up. Same thing happens when you go to a mall and pick up a shopping bag. The body is prepared. Recovery is faster. God forbid you get down from the same mall and you twist your ankle. 3 weeks and you're back because your body is used to impact. This is the role of exercise. Plateau breaking. Now, here's where the mathematical transactional aspect of exercise comes in. Exercise has nothing to do with the first 10% of weight loss. Absolutely nothing. It comes in the month 4 and 5, when after the first 10-15%, say a person was 100 kg, he comes to 85. His goal, according to the BMI markers, is 100 minus his height in centimeters. So if he's 175, which is average Indian is 165 to 175. You have told him you should be 70 kgs. The guy is an endomorph. He's never going to become 70 in his life. But if you have set that goal for him, he's not going to come below 85. He'll come from 100 to 85. He'll get stuck there. Then what? Then you're going to tell him, nahi, up or starving karo. You fast even more. You do more exercise. He cannot, because his body is not built that way. But the plateau correction, that is where exercise will come in. It will help you break that set point which ma'am talked about. Post the initial correction. So take the psychological role now. We've talked about physiology. Physiology is not very complicated. It's just muscle activation. Feel good factor. We all know 15 minutes of exercise improves your, and from dopamine to endorphin to all of it. It's practically a drug and it's free. change in identity. If you have lived in the shoes of an obese person, you know that every room they walk into, the obese identity is sitting on one shoulder, low self-esteem is sitting on the other. It is all pervasive in their life. They cannot escape that identity. We have so many of our employees who are now obese, unable to get married, rejections at the time of marriage, very difficult. We live in an online world now where everything is a selfie. Imagine being 110 kgs in a selfie-driven world. You will see that DPs. The DPs are always only the face, that too in a particular angle. These are all clinical signs. And if you have refined your intuition, you don't have to ask a patient his weight. Like, for example, in my clinic, there is no weighing scale because most of the patients I see, the weighing scale cannot even measure their weight. And I don't have a weighing scale. I can visibly see the weight. I just see the t-shirt size. What is the t-shirt size, man? Sir, triple XL, 4XL. Okay, fine. Let's come down to double XL in the next 6 months. That's good enough. See, that level of sensitivity and class when you bring into your communication, they don't see you as a threat of one more person who keeps talking about his weight because it's my agenda, not his agenda. Frankly, just because his weight came down doesn't mean I can guarantee he won't get diabetic. That's not the point. The point is, does he feel comfortable coming back to me? Because it's not a one-time transaction. It's going to take a whole year of patting him on the back. And that coaching role is where the doctor has to transition. It's not about abhi kitna kam ho gaya, abhi kitna kam ho gaya, aur thoda karo. No, it has to change. So this identity change in the patient is what we have to help him transform, which I'll show you ahead. A sense of control. Most obese people have lost a sense of control. No matter what I do, they say it doesn't come down. Fair enough. But if I stop asking the question, he'll stop having to come up with creative answers. And you will be surprised, obese people are among the funniest, most well-researched, most comfortable people, except in a particular social arena. When they have to do social interaction in a group, that is where they get constricted. But you meet them one-on-one, they will amaze you with who they are. They are just physically challenged, and very often it's not even lifestyle. Like ma'am said, it just may be in the genomics. It doesn't matter. They just need to be in an environment where nobody's judging them. They need to get a sense of control back. Like ma'am talked about, there are particular triggers of weight gain. There are multiple triggers. Like for me, a trigger is rice. I know if I give up rice, I'll drop 5 kgs in a month because it's my trigger. You just help an obese person find his or her trigger, and that's the end of story. Okay. Reduction in anxiety, depression. Now, exercise does all this. Exercise will give you a feel-good factor. It will give you a change in identity. You'll wake up as a cyclist. You won't wake up anymore as an obese person. Sense of control. Now, once you start getting those hobbies in place, you start feeling more in control of your day, of your life. Reduction in anxiety and depression. Why? Little endorphin shot in the morning, 15-20 minutes, back to normal. What are the pitfalls of exercise? Now, here's where the real problem starts. Weight training is an anabolic trigger for the body. So any one of you who's sending an obese person to the gym is making a cardinal mistake in phase 1 because you're underfeeding him. Remember, muscle has to be fed, fat has to be starved. You cannot do both at the same time. So never send an obese person to the gym when you're giving him less nutrition. Don't trigger anabolism with the exercise and try to trigger catabolism with the diet. That cannot work. The blood sugar will drop too fast. He will end up eating more, which causes more weight gain, which is why most people say, sir, I joined the gym, I put on 5 kgs. And the gym trainers will keep stuffing him with protein because protein is a satiety play. It's like high fiber. Some people give high fiber, some people give high protein. It's fine, but his body is partitioning protein to build fat because he's lifting weights. That's an anabolic trigger. He has biomechanical challenges, so he will not adhere to cardio, yoga, Pilates, anything where his body is not suited. So the pitfall of exercise is anything you tell him is difficult for him. Secondly, if you tell him, okay, you can do weight training, it's anabolic. Catabolic will trigger hunger. You have to be very, very careful when you prescribe exercise to an obese person. Now, high insulin resistance, leptin resistance, excess cardio, these 3 are classic hypoglycemics. If he's diabetic and on the glycomets of the world, another hypoglycemic. Imagine your blood sugar is 60, your weight is 140, and you're not eating and you exercise. It's checkmate. do not make an obese person exercise. It is impossible to exercise and not eat. It is impossible. So do not tell obese people to exercise for the first 6 months. It doesn't matter. It is a nutritional disorder. Fat has to be starved. Fat does not have to be exercised. We will exercise it after the first 20% of weight correction. Trigger eating is the biggest problem. The problem in obesity is hunger. The problem is not exercise. But exercise is the greatest hypoglycemic. The minute you exercise, you see people who come from a morning walk, they eat 4 rotis, 4 aloo parathas because they have walked. The blood sugar is low. The body is hungry. They have to eat. It's homeostatic. Now, what are stages of exercise in a weight loss program? Phase 1 is always simply muscle activation, and I'll show you how to do that. Stage 2 is where you start replacing the obese identity with an athletic identity, which means you help him now install a new identity. It could be a cyclist, it could be a swimmer, it could be a gymmer, whatever. In phase 2, once the initial hunger is under control, stage 3 is where he starts selling what we call autotelic goals. He starts telling himself, okay, I've done 10K cycle, I can now cycle 25. It's like the movie Inception. You just have to tell him, okay, go do it. Just pat him on the back. Trust me, in 6 months, he'll call you saying, sir, I biked 50 kilometers for the first time. The point is, you stop talking about weight, he will stop thinking about it. And weight is no marker or guarantee of health anyway. You just have to have sensible weight. For an endomorph, a 25 to 32 BMI is perfectly normal. He's fat fit. In fact, he's far fitter than the 18 to 21 low BMI diabetic who's struggling to gain any weight, and the minute he eats, his sugars go up. So if you compare the two, and he looks cachexic, he looks like he's got tuberculosis or something. So finally, the fat fit is better and much stronger. The bone density is higher. He can do a range of activities. Point is what? You have to realize at what stage he has to transition from stopping to talk about weight to starting to talk about an athletic identity to finally shifting to performance-driven agendas. Okay, I've कर लिया, weight loss हो गया, I want to be a cyclist. Okay, 2 दिन gym जाओ, 1 दिन yoga करो और 3 दिन cycling करो. No problem. Those 3 days of cycling, he will push the bar on his own. You don't have to give him training plans. We are obsessed with relevance. The problem with all of us is we are obsessed with gaining and drawing relevance from a patient. The surgeon thinks about surgery, the physician thinks about reports, the trainer thinks about training, the dietitian thinks. Everybody is drawing their relevance. Each one has to let go, and it has to become self-management of weight. Like we have SMBG in diabetes, there's SMW here. SMBW, self-management of body weight. You have to teach him how to fish, not give him a fish every day. Like for example, Vidya. Now Vidya may have been 75, 80 kg. I don't even know her weight because I don't check weight. I just know that she was wearing a 4XL t-shirt when she came to us first time. Menopausal. A menopausal woman cannot lose weight. It is impossible hormonally unless she's diabetic, uncontrolled that too. She just swam 2 days a week, cycled 2 days a week. You notice all her activities are non-weight bearing. Because of this body type, she cannot run. It's too heavy. She's in the higher 80 kg. She lost 10, 15 kgs, but that's it. We never told her come to 50 kgs because all through college, the 5 triggers of weight gain in a woman, from pregnancy to from menarche to menopause to pregnancy to marriage, there are so many triggers. So what we told her, you look, just align with 3 activities that you like. She on her own cycled 25 kilometers, does 20 laps of pool and does weights every alternate day. She chose this herself. We simply told her what not to do. In obesity, it is all about what not to do. And that is where the role of a specialist comes in. Not over-educating a patient on what is obesity, how does it work, what is insulin resistance. So 15 jnana points are not required. What is required? Okay, don't do this. You will get injured. Okay. Now, this is what a typical 12-month exercise diet combination looks like. Phase 1 to 3, which is the first 3 months, is clean eating. And the dietitians are far better to handle and customize this phase. So if you have creat issues, obviously we won't give you a high protein. But some people have vegan, some people have high fiber, some people do macronutrient counting. Whatever it is that works for you, if go to a dietitian, but clean eating, which means basically junk and carb restriction. Now, when you are junk and carb restricting, you cannot expect a patient to run and walk for 1 hour because he's not eating. Where is the fuel? So at this point, just a little staircase climbing. Again, mitochondrial activation in the largest muscles, the glutes, the quads, the calf muscle, that's it, and lower back. These muscles get activated just a little bit. Light yoga, that too, if they want to do. The entire exercise for the day should be divided into 5 minutes, just 3 or 4 times a day. That's it. The change in weight will primarily come from removing the obesogenic foods. He will become thinner and lighter. The next 3 months, still continue with the same, because they will now go in possibly for intermittent fasting. Because of leptin and reduction in insulin resistance, naturally they'll be able to fast. At this point, the biggest mistake is to jump into a gym. No cardio at all. Heavy weights, nothing is to come in here. They have to continue. Do not increase frequency, intensity, or duration. This is where most of the rebounds occur, because people assume I've lost 10%, I'm going to jump into the gym. Here, what will happen? The intermittent fasting will trigger another 10%, becomes lighter. Now, these two phases are about lighter. Now, once you've come, let's say a 100 kg person has come to 85 or around 82. This is where you start bringing in, feed the muscle. Now we will build muscle. The sarcopenia, which is there, which has happened. See, normally when you see morbid obesity weight loss, for every 3 kgs of fat, there's 1 kg muscle loss. This is normal. And because of that 5 kgs of muscle which is lost, the BMR comes down tremendously. That 200 kg surplus, which was 200 calorie BMR, which was coming from that muscle, has gone. So now to bring that back, we have to feed the muscle. Using carb cycling, you can Google carb cycling. It's a very famous dietary approach where you bring back the carbs slowly, build the muscle using protein and carbs. Light gym, again, do not go heavy. But now the weekend cardio, we call this fasted state cardio. On weekends, once you start fueling the exercise, say exercise has to be fueled. You cannot tell a person, go ek cycle chalao, but don't eat. It's not possible. Let him eat, let him cycle. The plateau will get broken now. There may even be a slight increase in certain body types. It's okay, because the muscle is being built. And as ma'am said, muscle does tend to weigh more than fat. But this is just calorie partitioning. The body is shifting ectopic fat into intramuscular adipose tissue. It is just a change of geography. It's not exactly. And what happens here is classic inch loss. In women, you will see toning. The tricep area will get very toned with the gym. After this, you have to again repeat the fasting, because the metabolic rate has got activated. Do not increase exercise for the first 6 months at all. It is very tempting to do that, because everybody thinks, if I do a little more exercise, I'll lose more weight. No, you will get more hungry. The more hungry you get, the more you'll eat. You will relapse very quickly. Do not. Exercise has only a role in plateau breaking. The most important part of exercise is the identity. That leads to lifelong behavior modification, as ma'am called it. What are preferred activities to prescribe? Non-weight bearing are critical. Never tell an obese patient to indulge in weight bearing exercise. He cannot do it. He's athletically challenged. Okay, so don't do that. Ideal combination for obesity management initially is light gym, light weights, do all the machines. The beauty of the machines are they activate from the head to the foot all the large muscles. A little bit of cycling, and at last yoga. This is the safest combination. All three of them are not very calorie expensive. In an hour, they will not burn more than 200 to 300 calories. The beauty of that is it will not trigger hunger. The thing is, androgenic hormones. The androgenic hormones have to get triggered. That happens in the gym. That is what increases the BMR. Do not send them just for catabolic thinking. Oh, the more calories he burn, the more weight he will lose. No, the more calorie he burns, the more he will eat. So catabolic is a double-edged sword in an obese patient. Prefer androgenic. The point is not to stimulate hunger. The role is not to spend calories. So this mindset change has to come. Okay. Goal cannot be just weight, as ma'am said. BMI is irrelevant in an endomorph. Now this person, there's actually the same person. This person's BMI is well over 30. That doesn't mean he's obese. Both of them are weight 100. What does it matter? It doesn't matter. What is different is the shape. So all patients have to change their shape. This convexity has to become a concavity. That's all. There is nothing else to it. The subcutaneous fat has to disappear. See, you cannot see the ulnar tuberosity. You cannot see the clavicles. Here, you'll be able to see the clavicles and the ulnar tuberosity. That's all I check in my clinic. That's all I check on Zoom calls. Patients have to simply show me their clavicle. That is a marker of axial obesity, or they show me this, their ulnar. Okay, if they can show me that, it's understood that his subacute fat is coming down. Do not get into weight number discussions. It's very embarrassing for them. Take this, a van is 2000 kg, a Mercedes is 2000 kg. Look at the power and the performance here. So we cannot talk about weight all the time. This is 800 cc, this is 3000 cc. A car can weigh more but increase cc. That's the beauty of the heart lung engines that we have. The muscles can drive the BHP, but the problem is we keep talking about the weight of the car. Similarly, we tell patients, if you're currently in a cow shape, the goal is not to become a thin cow, a sarcopenic cow. The goal is to become a horse who can eat grass and somehow metabolize muscle, a horse who can eat chana and metabolize muscle. So the calorie partitioning is perfect in a horse. The calorie partitioning is improper in a cow. So the weight is the same. So you have to use animal examples when you explain to patients. Stop talking about weight, start talking about shape. Okay, to make fat history, change fat geography. This is nutrient partitioning. This is the primary role of exercise. So form follows function. What exercise you do is what shape the body will be driven to attain. So if you start weightlifting, the body realizes, okay, I need to build muscle to lift those weights. It's an adaptive response. So exercise is a point to give adaptation triggers to the body one by one. Indians by definition avoid weight training. We just don't wait. In fact, I had a patient who told me once, I said, why don't you go to the gym? He said, I've kept a man to go to the gym. Aadmi rakha hai. I said, fair enough. Maybe that works in our country. So, it doesn't work that way. The minute you start any form of activity, the body will start changing the storage mechanism. As we call the blood current account, fat is a fixed deposit, and Indians love fixed deposits. We never break fixed deposits. The real storage has to be in a savings account, which is your muscle, which is nothing but glycogen. When you need energy, it should be on demand. It's like an ATM. If it's in a fixed deposit, it's not available. You want to go climb a mountain, where's the energy? You have to eat. Even though you've got more than 3 lakh calories stored, you can't climb the mountain because everything is in a FD. It has to shift to glycogen. The only difference between this and this is the location of the storage. This is intramuscular glycogen. This is visceral and subacute fat, and some intramuscular fat again, not glycogen. So this transformation in terms of partitioning is what exercise is for. It's not for vanity. It's not just to look thin. Okay. What is a doctor's role? The biggest problem in obesity management is YCOS. YCOS stands for who is captain of the ship. There is so much cacophony in obesity management because everybody is giving their own version of the gyan. It's like that elephant. One is holding the tail, one is holding the foot, one is holding the trunk. Somebody has to stand up and say, look, I understand physiology, I understand pathology, I understand everything. Somebody has to stand up. And trust me, when a doctor does it, it's the best. Because you guys understand a lot more of the human physiology. But for that, you have to step into learning, like Geeta ma'am has explained so much about the diets. You have to learn those things. It takes time to spend time with people like her. More importantly, read books. You have to learn the art of dietetics. It's beyond CICO, which is calorie in, calorie out. Imagine you're an obese patient. You come and you're passed like a passing the parcel from a doctor to a dietitian to a gym trainer to a psychologist to a physiotherapist to a spiritual guru to a yoga coach, and of course your family is there to give you advice. Where does a person go with all that? And when? In 1 year he's left to deal with all this. So there's a lot of cacophony that goes on in obesity management. Somebody has to play the role of captain. Somebody has to become Dhoni here. Now, typically, initially the dietitian does do it. But the minute there's a plateau, a dietitian sends them to a gym trainer. The gym trainer doesn't know physiology. So he assumes there's something medically wrong. They send to the doctor. The doctor says there's nothing medically wrong. Go to the psychologist. Psychologist says, no, you need to train harder. He goes back to the gym, gets injured, goes to a physiotherapist. After all this fails, he gets depressed and goes to a spiritual guru. Then he just takes up yoga. This is what typically goes on in an obese person's life. Spend 5 minutes with them. They will tell you this story. A doctor's role has to be you put your hand up and say, look, I'm here for you. I'm here for you. Before the wait, after the wait, during the wait, I'm here. Okay. Obesity management is not about diagnosis. It is just about responsibility. Are you willing to put your hand up and tell the patient, just forget about the numbers? I'm there. Just be a friend and a well-wisher. I have treated thousands of patients by simply putting the hand on their shoulder and saying, call me. That's it. I won't give you gyan, just call me. They just need somebody to talk to. I tell them, I don't need more patients. I can always use more friends. They become lifelong friends. And it's not about the weight. They just feel safe around you. And they have enough rejection issues as it is. They don't need one more person body shaming them. Okay. Some sample cases, I'll show you how it works. Yeah, 106 kgs. Typical, as I tell them, they look pear from the front and apple from the side. So it's combination of pear and apple. 106 kgs in just 3 or 4 months. This is typically the first phase of correction. Just when they do a little bit of carb restriction, a little bit of high fiber, little bit of, now he will shift to protein and he will start building that muscle. The shape has not fully changed yet. The visceral fat is still there. The point is, this to this is easy. This to the next step is where the real push has to happen. Now, this is typical morbid obesity, BMI above 40. You cannot expect him to become a bodybuilder overnight. There will be a shrinkage in t-shirt size. As you can see, it's typically axial. Just give him time. Develop sensitivity. It's not about which exercise to do. What exercise can this body do? We cannot really do much exercise. It's not built for exercise. Okay. So go gentle with them on exercise. Exercise is not a natural alignment for an obese person. It is not. It does not come naturally to them. Avoid transactions. I exercise so I can eat. Don't tell them this. If you ate, go and exercise. No. Obese people are not lazy. They just have a non-athletic body. They don't need more information, and never feed an obese person more clarity from their medical reports. They will use that as a leverage. Oh, you see, because I have this, that's why I don't lose weight. Don't go there. Just tell them as a friend, you know what, carry on. Just carry on. And that's why I don't have a weighing scale, because they keep doing their weight anyway. They will keep telling you, but I don't bring up that conversation. Yeah, these are some dictums I usually share with patients, which you can use. These are punchlines. Remember, diet decides weight. Exercise decides shape. Exercise is not for weight loss. Diet is for weight loss. And I usually come up with these jokes for them. Baba Malar, it's just a joke. See, we don't play doctor around them. We just play, it's all friendly. Dieting makes a person lighter. Exercising makes a person thinner. Remember this, thinner, not lighter. Fasting will make you lighter. Dieting will make you lighter. After the first 20%, first get into shape, then worry about weight. 20% comes initially, the plateau will happen. Then get into shape. Shaping is just simply starting any form of exercise. It is easier for an obese person to eat less than it is to exercise. Much easier for them to eat less. Don't make them exercise. Just tell them don't eat junk. They won't eat junk. You make him exercise, he has to eat junk. Never make an obese person walk or run more than 20 minutes. Never make them do this. This is the worst thing you can do to them. It's as good as giving them insulin and lowering their blood sugar. So don't do this. You are stimulating a relapse. Okay. Take home message. No human can exercise and not eat. Always do one at a time. First diet, then exercise with eating, back to diet, back to exercise. Never at one time. Okay. Remember, your whole goal is to reveal their inner athlete. There's an athlete in there. It's layered under all this. And the maximum of fat is between the 2 years. All that expectation fat is between the 2 years, what the world expects. Once you help them remove all that, it makes all the difference. Okay. So we'll take questions. Ashutosh?
Yes, sir. Thank you, Dr. Mallar, sir. It was a very excellent presentation on how these physical and psychological aspects of the it matters on the weight loss and management of obesity. I would also like to thank Dr. Vedavati Purandare and Dr. Geeta ma'am for their contribution in this CME of obesity management. So now moving further, we will have our question and answer session. So if any of the participants have any question, I would request them to kindly put in a chat box. So our first question is by Dr. Vishaka Katre. It is for Dr. Geeta ma'am, and she has a doubt like, is there any special diet for PCOS patient, PCOS female patient? Is there any special diet for them?
Yeah, Dr. Vishaka, it's a good question because we talked about hypocaloric environment, controlling the obesogenic environment. Again, a PCOS talks about first behavior modification, but more importantly, we look at insulin resistance or the insulin factor, where we control the carbohydrates, make the glycemic load of the meal very important. So first is calorie control, two is behavior modification, and three is glycemic load of the meal. I think this can be broad outline for the PCOS diet, but again, it is very personalized and it is a very, very individualistic approach to what a PCOS actually is looking for, a weight loss or an anti-inflammatory approach or whatever the person is actually going through.
Okay, thank you, ma'am. Our next question is by Dr. Satish to Dr. Mallar sir, and his question is how to maintain dedication for exercise in those obese patients.
Identity, Dr. Satish, identity दे दिया तो सब आ जाता है. You have to help him find that identity. It'll every identity that he creates, it's like the work identity. If he's a whatever, most of them are very intelligent and very good at whatever they do. Most of them are IT. They get up and go to work anyway. Similarly, they'll get up and go and exercise. The word is sampling. You get him to sample 3 or 4 exercise forms, he will automatically tell you, I really like this. And then he doesn't have to be pushed. You have to help him find that.
Okay, thank you, sir. Our next question is by Dr. Girish, and his question is to Dr. Geeta ma'am. How many times one should eat per day? Is it a 2 times, 3 times? Many of the people follow, which is a very famous Dixit diet, where they eat twice a day. They keep a gap of 12 to 14 hours in between. So
Geeta,
how helpful exactly is this diet?
I think each one of the panelists can contribute to this question because a very, very common question and everybody knows the answer here. I again come back to personalized nutrition, and we should eat as our body permits us to understand the energy requirements. Eat when your body needs energy. If you want to eat, go into proper intermittent fasting with a good way of approach of 12 to 14 with a balanced nutrition 2 times a day. Every secondarily doesn't work because you're constantly food focused here, and then that increases your calorie intake. So think that what kind of energy requirement you want, what is sustainable for a long term. 2 meal patterns should be looked at intermittent fasting, not a time restricted diet. Then that will nourish you, and it will help you to have a better goals of fat loss and muscle gain.
Okay. Thank you, ma'am. Our next question is the role of gastric artery embolization. I think this question Dr. Neeraj would answer, but in the next session, where he will be speaking about the role of a bariatric surgery and all. So definitely we would ask this question that time. So the next question, it is for all the panelists, and the question is from Dr. Meenal Khare, and it is a general question, and her doubt is how to reduce weight post-pregnancy. So it is open for all the panelists.
Let's start with Dr. Vedavati then. Ma'am, over to you.
Yes, so in our part of country, pregnant ladies, there are a lot of myths related to diet. They have to have saturated fat, they have to have sugars. So we have to tell that during the pregnancy itself, it is not like high calorie stuff and high fatty stuff they have to eat. It is about a balanced diet which will give them more of micronutrients and balancing macronutrient intake. So prevention of that extra weight gain which occurs because of lot of myths in the diet related pregnancy, that we have to counsel. And basically for all pregnant and recently delivered women, we have to tell them that it is not just, many of the females are leading a lot of sedentary life when they deliver. So it is like if your baby sleeps, you can do some small steps inside your house. In Marathi we call it as Shatapavali. So it is not like baby is sleeping and you have to also sit besides the baby. So just increasing physical activity a bit and just restricting saturated fats and simple carbohydrates, not like completely stopping, but the excess which usually is followed should be curtailed, is what I feel.
Okay. So next question is to you only, ma'am, from Dr. Gayatri Kasa. Is there any special approach for obesity management in hypothyroid cases?
Basically, hypothyroidism, we have to treat properly and keep TSH so that their basal metabolic rate is fine. And in addition to managing thyroid by proper thyroid supplement dose, they have to just follow balanced hypocaloric diet to keep their weight. And then otherwise, as Dr. Geeta and Dr. Mallar has beautifully explained in their sessions, that just helping hand and individualization of therapy regarding weight loss and weight maintenance.
And another question is there any role of an antidepressant as an add-on to obesity management?
We do see that a lot of patients who are obese, and that too morbidly obese, they suffer from depression. But not all we give antidepressants. If they have symptoms of severe depression, we send them to a professional, that is psychiatrist. If he assists, if he says that patient needs antidepressants for his depression symptoms, then only we give it, not for all.
Okay, okay. Thank you, Dr. Vedavati, ma'am. Next question is to Mallar sir. How to decrease the abdominal fat? It's from Dr. Jyotsna.
Yeah, the most common question, we call it Madhya Pradesh. Madhya Pradesh kaise kam karna hai? That's a standard question. So I usually tell them use a istri. वो istri को गरम करने का और उधर istri करने का और side से रंदा मारने का ऐसे. So it's nothing. It just takes years of dedication at a particular activity, getting better at it. So I've been a triathlete for 15 years. Whenever you pick a sport, no athlete has visceral fat. You have to become an athlete. There is no option. So whether it's cricket or it's swimming or cycling or gymming or yoga, you have to become that. Otherwise, it'll just be 2 days, 2 steps forward and 3 steps back. So any one of you who wants to know how to reduce visceral fat, it shows that you are not a specialist of any particular sport. And sport doesn't have to be a profession. It just has to be a passion. So it could be gymming also. But it's got to be 6 days a week, 1 hour a day. Visceral fat will go away.
Okay.
Ashutosh, I would like to add here something.
Yes, sir.
Basically, it is the expectation mismatch. Anybody who wants to start the journey of weight loss or fat loss has to have realistic expectations. And as we discuss internally amongst ourselves, loss of fat in the abdomen or the truncal fat, truncal obesity is the last to go. So once you all know that, we all know that that is the one which is going to go last, that's the realistic expectation. And if we begin on that realistic expectation note, then probably we can have better outcomes.
Yes, sir. Correct, sir.
Also, Ashutosh, it's not a weight issue. Abdominal fat is never a weight issue. It's a shape issue. To change shape requires exercise. To change weight requires diet. So you do as much dieting as you want, the visceral fat is going to go nowhere. That requires sustained exercise of a minimum intensity. So walking a mile, we call it a walker's belly. You can keep walking kilometers around grounds. The abdominal fat will be like that only. The day you switch to exercise specialization, in 3 months, it will be gone.
Yes, sir. Very well said. So as there is no further questions, so we will move forward. So I would sincerely thank Dr. Vedavati Purandare, Dr. Geeta ma'am, Dr. Mallar sir for your excellent presentation on introductory aspects of obesity, its nutritional management, the role of physical and psychological in the management of obesity. So let's move. So our next talk will be by Dr. A.G. Unnikrishnan sir, and he will be talking on current novel therapies for weight loss. So Dr. Unnikrishnan sir is a CEO and Chief Endocrinology at Chellaram Diabetes Institute, Pune. He heads a clinical care, research, education, and also oversees a philanthropic rural diabetic care program. Dr. Unnikrishnan has co-authored the largest multi-center study of a subject with pancreatitis and pancreatic diabetic worldwide. In addition to his many other almost more than 190 PubMed index publication, which is a huge. He is also a former editor-in-chief of a Journal of Thyroid Research and Practice and former executive editor of Indian Journal of Endocrinology and Metabolism. He received many awards during his academic career, including a Jacob Memorial Prize for the Best Patient Care awarded by CMC Vellore in 1998. He has received a Subhash Mukherjee Oration Award of Endocrine Society of India in 2011, Srivastava Award of RSSDI, which is India's largest diabetes society, in 2011 for his contribution to diabetes. He received a Fellowship Award of RSSDI in 2017, Dr. Sam G.P. Moses Oration Award by Diabetes Association of India in 2018, Diabetes Excellence Award at Digital Diabetes Summit at Hyderabad in 2019, and recently in 2020, he delivered the Madhukumbha Oration at Annual Diabetes Association meeting at Nasik, Maharashtra. Over to Dr. Unnikrishnan sir, who will be speaking on current novel therapies for weight loss. Thank you.
Thank you very much, Dr. Ashutosh. It's a pleasure to be here. And I hope my slides are visible and that I am audible.
Yes, sir, yes, it's visible.
So I'm going to talk about current and novel therapies for obesity. We've already had good session on physical activity and diet. So I will go straight to therapies. But I want to acknowledge here that diet and exercise are among the most important aspects, not for weight reduction alone, but for cardiometabolic health in obesity. So just to acknowledge the prime importance of diet and exercise, and what comes later is next. So somebody asked a question about bariatric embolization, and this is a study which was published in 2019 called the BEAT study. And you can see that bariatric embolization was done in this lady. Just a minute. The baseline weight of this lady was 115 kilograms, and the BMI was 48. And you can see here that there is a left gastric artery and arising from the proximal part of the celiac artery. And along with the left gastric artery, there is the left gastroepiploic artery. And you can see both these arteries have been embolized. And the patient lost weight loss of 16 kilograms in 1 year, 30% excess weight loss. And this is the important paper which was published called the BEAT study. And this is a mean excess weight loss. So you can get about 8 to 10% excess weight loss, but you can see the confidence interval is pretty wide given by the dotted lines. So on that note, let me come to a case. Diabetes. This lady had diabetes for 11 years, has neuropathy, nephropathy, and retinopathy. We call it triopathy. Hypertension, coronary artery disease. She was on 100 units of insulin, sitagliptin, metformin, sulfonylurea. The HbA1c was 12%. The creatinine was borderline 1.8. C-peptide was good. The BMI was 49.6. She tried lifestyle modifications and other therapies with no success. So you have obesity, diabetes, hypertension, coronary artery disease, sleep apnea, osteoarthritis, diabetic complications, left ventricular hypertrophy. So all the complications. So she went for weight reduction, specialized diet, liraglutide was added. This is just to give you an idea of the various therapies. And with liraglutide and diet, she lost 10 kgs pretty quickly. And then she underwent bariatric surgery at our hospital, sleeve gastrectomy she underwent. And immediately in the evening of the surgery itself, we actually mobilized the patient because, as you know, bariatric surgery isn't a very, it's a very commonly done surgery nowadays. And luckily, there are good expert bariatric surgeons to do this surgery. And she underwent a bariatric surgery. What you can see is that with bariatric surgery, the weight loss was good. 126, and within a month, it came down to 100. HbA1c 12 to 7.6, 100 units of insulin to 10 units. Sitagliptin and sulfonylureas were stopped, and she was only on metformin. Sleep apnea symptoms had gone away. And this is to tell you that in addition to diet, exercise, we talked about liraglutide, we talked about bariatric surgery. So these are the current drugs. But what are the future drugs in the pipeline? So some of the future drugs in the pipeline act on the stomach, some act on the brain, some act on the intestine, some act on the liver, and some act on the kidneys. All these drugs cause weight loss. But remember, these drugs are in addition to diet and exercise. Many of them haven't been approved, and some of them act through multiple pathways. For example, the GLP-1 receptor agonist will act at the stomach, act at the brain, and also act on the liver. So just to give you a highlight of this is that many of these drugs try to mimic the effects of bariatric surgery. So let's look at some of these agents. And the most important among these agents, which I will focus on, is a GLP-1 receptor agonist. As you know, GLP-1 or glucagon-like peptide 1 is formed from the L cells of our intestine. So imagine that you're having food and the food stimulates the L cells of the intestine to produce glucagon-like peptide 1. And glucagon-like peptide 1 acts on the pancreas to make the pancreas produce insulin, suppress glucagon. And this GLP-1 also acts on the brain to suppress appetite. So therefore, this incretin modulation that happens in bariatric surgery, which is a form of surgical incretin therapy. We are talking about now medical incretin therapy, and some of them also act on ghrelin, which is a very important player here. We talked about bariatric embolization, where selective embolization of the blood vessels to the fundus of the stomach is done so that ghrelin is reduced. Ghrelin is a hormone that's produced from the stomach, which tells people to eat more and exercise less. And if you block the ghrelin hormone, the brain will know that it's time to exercise more and eat less. The brain already understands that, but now the brain will know it in a way that the brain can implement it. But this is one therapy already available in some countries, soon coming to India as well. Semaglutide, it is unlike the GLP-1s available in India today. The current GLP-1s have to be injected daily. This can be injected once a week, subcutaneously. And at the dose of 1 mg once a week, it has been approved in many countries for the treatment of type 2 diabetes. It's licensed as monotherapy in people not able to take metformin. An oral formulation is already available and used in clinical practice. So the absolute weight loss with semaglutide has ranged from 4 to 6 kgs. But there have been, so this is in people with type 2 diabetes and obesity. And the other agent, dulaglutide, which is already available, is not very good for weight loss. Semaglutide is better for weight loss. We doctors, diabetologists, endocrinologists, we prescribe dulaglutide for obese people with type 2 diabetes, and it controls the sugars very well. But semaglutide will also cause weight loss. Recently, one study reported that oral semaglutide at a dose of 14 mg once a day caused more weight loss of 4.4 kg. They were not approved for obesity, but they will be approved for obesity because this is the landmark study called a STEP study. Why is this a landmark study? This was done for people who had obesity, but who did not have diabetes. So this study, in fact, we at the Chellaram Diabetes Institute were also one of the centers for the study, and Dr. Neeraj Raite and Dr. Patan Shetty were also co-investigators of the semaglutide injection in non-diabetic obesity study. And the results were published this year in the New England Journal of Medicine. And you can see the weight loss was very good. In fact, almost 15 kilograms weight loss and 15% of the body weight was lost. So this is a very good result, and waist circumference also came down by 5 inches. I'm not saying that diet and exercise will not produce this benefit, but imagine diet and exercise helping people to lose 15 to 20 kgs, and then this injection coming in to lose another 15 kgs, and patient loses 30-35 kilos. And that, not just from a cosmetic perspective, from a cardiometabolic perspective, that augurs very well. So you can see that there is a very good weight loss this injection. But the future is not about this injection, because this injection, which is a GLP-1 receptor agonist, acts at its receptor. It increases insulin, suppresses glucagon, results in weight loss because it acts on the brain as an anorexic. But there are two other peptides that we have heard about. This is GIP, or glucose-dependent insulinotropic polypeptide, GIP. GIP will increase insulin, but there are two problems with GIP. It causes obesity and it increases glucagon, which drives hyperglycemia. So can we take off the bad effects of GIP and give only the good effects of GIP? So can we just increase insulin? Let's come to that. But before that, let's look at glucagon. Now, glucagon is traditionally thought of a bad hormone. It causes hyperglycemia and it is diabetogenic. But remember, glucagon also causes energy expenditure and weight loss. So the question that many scientists are asking is, can these hormones be combined to get all the good effects of all the three hormones and remove the bad effects of these hormones? So probably combining hormones is not the answer, but using a single peptide which can act at the post-receptor pathways of these hormones to give it only the good effects is a very exciting thought. And such molecules are already available. One is oxyntomodulin. It acts on GLP-1 and glucagon. We know that oxyntomodulin is a peptide. Some of us will remember MBBS days where we know that oxyntomodulin is produced by the enteroendocrine cells of the intestine. And oxyntomodulin can suppress food intake, suppress appetite, and also increase energy expenditure in many ways. By acting at GLP-1 receptor pathways, it reduces food intake, and activating the glucagon pathway, it can increase energy expenditure. So now this is the latest molecule, this GIP and GLP-1 receptor dual agonist. We know that the gastric inhibitory polypeptide or the glucose-dependent insulinotropic polypeptide, GIP, is a peptide produced by the K cells. GLP is a peptide produced by the L cells. Now, combining GIP and GLP have opposing effects on glucagon because GLP-1 suppresses glucagon, GIP increases glucagon. But both of them can have an important effect on obesity and weight loss. So initially, some human studies were done which demonstrated very good outcomes for weight reduction. And the weight loss was reasonable at the end of 3 months. So then this molecule, which is now in advanced stage clinical trials, this molecule is called tirzepatide. And this paper is just published in the New England Journal of Medicine. And the authors chose to compare tirzepatide with semaglutide. Remember, I showed you that semaglutide can cause weight loss of up to 15% of body weight or 15 kgs. And they compared tirzepatide with semaglutide in a very short 40-week study in 1,879 people. And what they found is that this was, of course, on diabetes. So in diabetes, the weight loss may not be that much, but in non-diabetic obesity, the weight loss is more. But they found that semaglutide was good, as given in the gray color, but tirzepatide was better. Even the lowest dose of tirzepatide was about 5 mg was better than 1 mg semaglutide, and tirzepatide 15 mg produced even more weight loss than semaglutide. So semaglutide caused a weight loss of 6 kgs in the short study, and this caused 11 kgs, so almost double the weight loss. So this study, SURPASS study, showed that tirzepatide achieved non-inferiority compared to semaglutide. But once the non-inferiority was met, researchers went on and did an exploratory, are allowed to do that exploratory analysis once the primary non-inferiority is met. And when they did that, they achieved superiority. So the future is going to be of diet, exercise, and very exciting peptides. And of course, bariatric surgery will never go away. This drug also reduced lipid levels. So very interesting drug, injected once a week, acting on GLP-1 and GIP, causing dramatic weight loss. And that brings us to the triple agonist. And this is a very, very new concept. So triple agonist, this is a unimolecular triple agonist. It's a single molecule. And this molecule acts at GLP-1 receptor, GIP receptor, glucagon receptor. Remember, GLP-1 receptor activation causes weight loss, improves blood sugar levels, and suppresses glucagon. GIP causes weight loss, and selective glucagon antagonism, using the good post-receptor pathway of glucagon, causes weight loss via energy expenditure. So combining these three will give you good effects of all the three. So GLP-1 will cause weight loss and diabetes control. GIP will cause weight loss, and glucagon will cause weight loss. So all the good effects can be combined into a single molecule which acts at the receptor and post-receptor pathway of 3 targets. So this is called a unimolecular triple agonist with a multi-modular pathway. Very exciting, but as you know, the more exciting the molecule is, many of these exciting molecules don't see the light. So we will be left with diet, exercise, and of course, bariatric surgery. But meanwhile, this is a paper which was just presented 10 days ago at the European Association of Study of Diabetes in September. And I got it from Dr. Patrick Holmes, who put up this screenshot on Twitter of this paper. And this is the LYS 3437943. I call it the triple G because it's an agonist of GIP, GLP-1, and glucagon. So this is the first human phase 1 trial of about 47 subjects, and the drug has got a 6-day half-life. Remember, all these drugs have got side effects. These drugs cause nausea, gastrointestinal side effects, diarrhea, sometimes constipation, vomiting, and partly that nausea and vomiting is what causes hunger to go away and eat less food. So 3 mg was well tolerated in the study and transient heart rate. So you can see this one injection by the 8th day. This is within 8 days of taking the injection, people achieved a weight loss of 3.5 kilos. So one injection at the end of 1 week, you are getting about 3.5 kilograms. So mean weight loss was maintained up to day 43. And you can see the very quick effect. The higher the score, the lesser the appetite. So the VAS parameter is a parameter of satiety, and you can see satiety is shooting up. Satiety is and feeling of fullness after a meal shooting up immediately. So this triple receptor agonist has now undergone a phase 1 trial, which is just presented, and this is going to be very exciting because a combination of these drugs could control obesity. It's very easy to think of obesity as being a problem of diet and exercise, but diet and exercise is not why obesity occurs. Not eating, or rather eating junk food and exercising less, is how obesity occurs. But why obesity occurs is not explained by calorie in and calorie out, as talked about by Dr. Gandla. Why obesity occurs is a complex interplay of lifestyle, behavior, genetics, and biology. There is a biological component which is inescapable in obesity, and these new molecules try to address that. So by using a GLP-1 agonist, these drugs can help in weight loss, improving insulin, and decreasing glucagon. By targeting a particular pathway of GIP, it can increase insulin. And by targeting a particular pathway of glucagon, it can cause weight loss and energy expenditure. GIP is not all good. Some people suggest it may be obesogenic, but by increasing insulin, it may control diabetes as well. And because of its complex effects, overall, this triple agonist, the way they interact with each other, has been shown to cause weight loss. So amylin is another molecule which has been tried, and amylin is co-secreted by the pancreatic beta cells with insulin. It inhibits glucagon and has satiety, but the studies have failed. People have talked about leptin, and metrileptin is a subcutaneous analog, but leptin also did not really work because the weight loss with leptin is only about 1.5 kilograms with metrileptin. Lots of other agents coming up. You have the ghrelin vaccines and the agonists. You know, ghrelin is an orexigenic hormone. It tells people to eat and eat and eat. It's produced by the stomach. The human trials of ghrelin agonists have been disappointing, but vaccines are coming interestingly. Neuropeptide Y inhibitors. These drugs, neuropeptide Y is a bad neuropeptide. It makes us eat. So inhibiting it will make us eat less. And they act via so many pathways. But these trials have also so far disappointed. Melanocortin 4 agonists. In people who have a melanocortin 4 receptor mutation or melanocortin deficiency, some of them, where there is a melanocortin deficiency, these agonists have caused weight loss of 51 kilos. But in other people, traditional, non-syndromic obesity people, the trials have been disappointing. So I'd like to conclude by once more highlighting that, yes, bariatric surgery is a treatment for massive morbid obesity. Yes, there are some medicines which work in obesity, but the future medicines for obesity are very exciting. But the fundamental treatment of obesity is reducing food intake, improving exercise. But to help that is how obesity occurs. But to target why obesity occurs, you'll have to look at behavioral aspects, the psychology, the biology, and also the community, the obesogenic environment that predisposes people to obesity, the easy availability of junk food, the lack of opportunities of people to exercise in public places, urbanization, the affluence and prosperity which is driving junk food consumption. So obesity is a complex disease and the solutions are complex. Meanwhile, let me thank Dr. Ashutosh for inviting me to this meeting of the Chellaram Diabetes Institute. We are very glad to be able to host this meeting, and thank you so much for listening to me.
Thank you, Dr. Unnikrishnan sir, for your excellent presentation on novel therapies, where we have seen many upcoming molecules we can see, which will be changing, which will be which will help in reducing the weight in obesity management. Now, moving further, as we are short of time, so the next talk will be by Dr. Neeraj Raite, who is a bariatric surgeon and empaneled at Chellaram Diabetes Institute, and he will be talking on interventional options for weight loss. So Dr. Neeraj Raite is a laparoscopic GI and bariatric surgeon. As I said, he is empaneled with Chellaram Diabetes Institute. After completing his medical education in India, Dr. Raite completed his advanced training as a fellow at Department of GI and Oncosurgery at Athens Medical Center in Greece. And he has a special interest in robotic and laparoscopic GI and bariatric surgery. He has also co-authored books on minimally invasive surgery in gynecological oncology and esophageal cancer, and has contributed technical papers to several reputed journals. He has conducted several live surgical workshops to demonstrate technically demanding procedure, which were broadcast live to international audience in US, Italy, Turkey, and Singapore. So over to you, Dr. Neeraj sir, for interventional option for weight loss.
Thank you, Dr. Ashutosh. Thank you, team Chellaram, for organizing this beautiful conference and sharing knowledge on science of weight loss. As it was rightly said by all the faculties, probably when we will visit history, we will realize that the world has been divided into two important eras, the pre-COVID era and post-COVID era. What has changed in respect to weight loss or obesity is that in the post-COVID era, there has been a polarization in the weight. So there are few who have worked a lot in this time and have managed to lose weight, while there are others who have been not able to give justice to themselves for whatever reasons and have gained weight significantly, leading to this dramatic shift. So I don't want to clutter my presentation with images of before and after. Rather, I would love to share the philosophy the way Dr. Mallar shared insights. And I'm sure these insights and philosophies will give all of you here an idea that how comprehensively the team at Chellaram Diabetes Hospital is working from all angles of diet, exercise, medical management, endocrine management, and when none of them work, from the options of interventional therapy. So we all have experienced when we talk to our patients, and this is the usual patient story when they become obese. They come to us, they listen whatever we try and tell them, and their expectation is all shouldered on us, expecting us to work more for them than they working themselves more on their weight. And probably here we will have to begin our making things straight to them and giving them perceptions that it is no longer about kgs, but it is all about the persona which they will take and carry forward. It is a usual story. They have gone to every possible person who has advertised a pill in the newspaper, a machine in the advertisement or an advertorial, or a powder which is sold at multi-level marketing. And despite all those efforts, they are directionless and land up with us expecting that we will give them result. And the journey begins with giving them insight that it is not the people with them, but the person within who is really going to bring the change in them. There are some important concerns which I would like to highlight. A typical weight loss in diet and lifestyle programs for severe obesity has been observed only in the range of 1 to 3 kilogram per meter square, in comparison to 13.5 kilogram per meter square after interventional procedures. The bigger challenge is keeping them engaged because the attrition rates are high when diet and lifestyle programs make them work but don't focus on compliance. And even when despite being these therapies successful, a lot of them drop after expected weight loss and bounce back, which is a usual experience of all of us. The other thing is patients who are extremely obese, having a BMI more than 35 per kg per meter square, in contrast to those who are class 1 obesity, having a BMI in the range of 30 to 35 kilogram per meter square, have not been able to either reduce or even if they reduce, maintain their BMI with only lifestyle modifications. Well, you may find my statements little contradictory at the end, but what I am trying to emphasize here is that no one therapy can be a full shot solution, but it is the combination of all of them working together for a common goal, which is not only focused on kgs, but overall physical well-being of a patient is something which is going to matter. Thus, it has been observed in multiple meta-analysis that the success rate of 120 centers in the world specialized in outpatient obesity care in treating patients for obesity, only 7% of them could hold their patients after the period of 24 months. The biggest challenge we as clinicians face is a syndrome of what if. We all feel that what will happen to our patients if we enlighten them about the options of interventional weight loss measures. We all feel that will our patients comply? And I think as a surgeon, what we expect from family physicians or the physicians is to just give them an insight and let them do their own research and analysis before they can take their call. Here is a question for everybody. How would we manage this patient who is a 40-year-old male having a 40 BMI, non-diabetic hypertensive, but not responding satisfactorily to any measures of medical and lifestyle management? Now, this is a catch-20 situation where if we can enlighten them about the option of interventional weight loss, an appropriate decision for their appropriate body mass index and physiology can help them to have good quality of life in the longer run. So the recent trend in bariatric surgery has changed from focusing only on treating excess weight to better treating overall metabolic syndrome. And that's how we believe that it is never the surgery only which is necessary, but there is a role of comprehensive team like we have, which can help our patients effectively. There is a debate about which surgery can be appropriate to our patient, and you can't just do one type of surgery like sleeve gastrectomy, which is a predominantly restrictive surgery, or a bypass, which is a predominantly malabsorptive surgery. But our focus in caring our patients should be constructive and appropriate for their physiology and their pathology. The other debate, which is taking a big time now in the field of surgical intervention, is reversible procedures versus non-reversible procedures. The major shift which has happened in the care of obese patients is acceptance by the insurance companies of their care for an option of bariatric surgery, which now gives a validation that yes, this option is also effective and is accepted by the agencies or the institutions which are helping in care delivery. We as surgeons have now realized and have accepted the necessity of continuous diet, exercise, and lifestyle modification despite the patient undergoing bariatric surgery. And you must have heard through every clinician here that the emphasis has been always on diet, exercise, and lifestyle modification. So thus we all know now that when other treatments for severe obesity are unsuccessful, it is prudent that we consider use of interventional weight loss measures like bariatric surgery within the context of existing guidance. And here I will share the few established options which have been in practice for last more than 10 years, which have been offered to patients and have been chosen on case-to-case basis. So we all accept that when non-surgical measures do not work, we will have to ultimately offer our patients interventional options. But what should be the choice? These days, there are some patients who come to us thanks to media management with solutions which they have chosen for themselves. They will come, they will read somewhere that there is a pill which can be taken and that can help in weight loss. They have seen their nearbys who have undergone a surgery like sleeve will come and tell us that I need to undergo a sleeve. But although these are the kind of choices which patients come and propose us, I strongly believe that between balloon, sleeve, gastric bypass, and one anastomosis gastric bypass, individualization is the key to success. One size will not fit everyone. So here I would love to quote the quote which has been taught to me by the masters of bariatric surgery with whom I worked with their fellowship. And they always used to say that you should consider a choice which will help our patient only once, and let that choice should be the last choice for our patients than they undergoing multiple attempts and failing and losing the trust on the care delivery. So let us try and understand what is an endoscopic gastric balloon. This is a procedure where a gastroscopy puts an inflatable silicone balloon inside the stomach, and this balloon is filled under general anesthesia to a capacity of around 300 to 500 ml. This is a purely daycare procedure and patient can go home on the same day after the procedure. And the biggest advantage is that it's a reversible procedure. The balloon needs to be removed 6 months down the line to 1 year down the line. And then again, the role of diet and exercise will come into play. This is a kind of picture the balloon looks like inside the stomach, and this is done endoscopically. The realistic outcome expectations, as we mentioned in our panel discussion, has to be briefed to the patient in clear language, where the weight loss is in the range of 15 to 20 kgs at the end of 6 months. But the key here is commitment and motivation of the patient for diet and lifestyle modification, which is also used along with this balloon. And that is why these patients need close and regular follow-up and counseling. The common side effects are usually in the immediate after the insertion of balloon in the type of nausea and spasmodic abdominal cramps, which usually resolve as the stomach adapts to this foreign body inside the stomach for temporary period. Sleeve gastrectomy, we all know, is an established modality, so I don't want to go into the details of what is sleeve and how it works. The important limitation of sleeve gastrectomy is it's an irreversible procedure. So the indications for sleeve gastrectomy these days have become little limited. Usually it is performed in elderly patients and highly comorbid patients where we have to be quick in, quick out so that the anesthesia time for the patient is reduced. The contraindications for the sleeve gastrectomy is the presence of hiatus hernia or gastroesophageal reflux disease, and that is why role of preoperative endoscopy plays an immense role while choosing a sleeve for our patients. Gastric bypass are of two variants. One is a Roux-en-Y gastric bypass, where there are two anastomosis, one at the site of gastroesophageal junction, and the second is at the lower part, which is a jejunostomy. This basically bypasses the proximal part of the jejunum and gives a strong metabolic effect. The advantage is it's a reversible procedure. Indications are the patients who are in the metabolic syndrome, and the contraindications are cirrhotic patients or smoker patients, because this is a strongly malabsorptive procedure. The other challenge we faced after the patients undergoing a Roux-en-Y gastric bypass was they used to say that, "Sir, pot bharta, pan man bharat nahi." Since the pouch size is 30 to 50 ml, many a times patient does not get psychological satiety, although their abdomen is full. And that's where this new surgery is in vogue, has been now quite routinely performed in Indian subcontinent, and it's called as one anastomosis or a mini gastric bypass, where there is only one anastomosis between the pouch of a sleeved stomach and the proximal jejunum. We have found very good results with this surgery, especially in Indian subset of patients, because Indians predominantly are volume eaters. It also can be made a strongly malabsorptive procedure in super obese patients and can give good results in them. Again, the contraindications remain the same for any bypass because these are malabsorptive procedures. Smokers and cirrhotic patients cannot be offered this surgical option. So to summarize, bigger trend of gain in weight is going to be here to stay, and considering bariatric surgery will have to be accepted as one of the treatment option. Only probably lasting trend will be adoption from a single modality to a multi-modality based on case-to-case basis, which suits and is appropriate for our patients. One of the question was asked about embolization of the vessel, which is called as a BEAT trial, bariatric embolization of artery for treatment of obesity. There was a recently published systemic review and meta-analysis where they mentioned that left gastric artery embolization was associated with statistically significant weight loss and limited complications during short-term follow-up. Now, this is what is the usual story of lot of doctors, or for that matter, lot of patients who Google a particular thing. And the issue is that we tend to take only things which suit or are convenient to us. In the later half of this study, it has been also mentioned that LGA embolization is still an investigative method. Thus, friends, it is my earnest request to anybody and everybody who is in care of weight loss and obesity that let's not make a generalization saying that so and so treatment can be administered easily without complications, inducing an appreciable weight loss with statistically significant reduction in BMI and an improved in associated comorbidities. We will have to be case specific. What looks evil can be good if it is looked upon with a positive mindset and a team approach. When I started working in the field of bariatric surgery, physicians and surgeons used to be in a mode of having a fight amongst each other. And I'm happy that we are shifting our mode from fighting amongst each other to collaboration and working together for the betterment of our patient and helping them to have a better quality of life. Thank you so much for your patient listening.
Thank you, Dr. Neeraj Raite, sir, for your excellent talk where you have discussed various surgical options for weight loss and obesity management. Now, moving further, we have our international faculty with us, Professor Dr. David Cummings. He is a professor of medicine, senior investigator at University of Washington Medicine Diabetes Institute. He is the director of weight management program, Puget Sound Healthcare System. His special area of interest is endocrine regulation of appetite, body weight, and glucose homeostasis. He is a recipient of an honorable Presidential Early Career Award for Scientist and Engineer. It is the highest award conferred by the US government. So over to you, Dr. Professor David Cummings, sir, and he will be talking on the mechanism and impact of metabolic bariatric surgery on diabetes, cardiovascular event, and mortality. Thank you.
Thank you. Can you hear me okay?
Yes, sir. Yes, sir.
Okay, let me share my screen. Thank you very much, everybody, for inviting me to speak with you today about the mechanisms and impact of metabolic bariatric surgery on diabetes, cardiovascular events, and mortality. First, let me disclose that I'm on the following scientific advisory boards. I'm going to talk about four things today. First is to talk about some of the evidence demonstrating weight-independent mechanisms of remission of diabetes following bariatric metabolic surgery. And the existence of these weight-independent mechanisms helps justify use of these operations specifically to treat diabetes as the primary goal, even in lower BMI people who don't lose all that much weight after surgery. And this is particularly germane there in South Asia. Then I'm going to go through some randomized controlled trials that have directly compared surgical versus non-surgical approaches to diabetes. Then some larger, longer-term studies with hard outcomes such as cardiovascular events and death. And finally, based on these above bodies of evidence, close with some exciting new policy implications that are changing the landscape of metabolic surgery worldwide. So let's start with the mechanisms of diabetes remission following metabolic surgery. I'm going to primarily focus on this operation, Roux-en-Y gastric bypass, which I will abbreviate as RYGB. As you just learned, this consists of two anatomic components, mainly a reduction of the gastric capacity and the creation of a small proximal intestinal bypass. Now, the stunning statistic about this operation is that if you have type 2 diabetes and undergo it, you've got about a 70% chance of going into complete remission and thereafter being normal glycemic off diabetes meds. Now, I'm an endocrinologist, not a surgeon, and I think of diabetes as this chronic, progressive, relentless disease where we're just trying to stave off the complications. So the idea that most people can be rid of the disease completely is absolutely stunning to me. And it begs the question, how does it work? And could the answer to that help guide us to new drug targets? Well, the most obvious answer is, well, of course, you lose a ton of weight. And with that, you're going to have improved insulin sensitivity. There's no question that that occurs. Long after weight loss, a year or two or three later, many people have shown improvements in insulin sensitivity in all the relevant organs like liver, muscle, and pancreas. The much more important finding, though, is a bunch of large bodies of evidence demonstrating many weight-independent mechanisms of diabetes remission in addition to the benefits of weight loss. In short, these include favorable changes in gut hormones, bile acid signaling, gut microbiota, the uptake and utilization of glucose by the gut, changes in nutrient sensing in the proximal intestine that confer benefits on insulin sensitivity, and alterations in iron metabolism, which acting through HIF2 alpha, a transcription factor, confer benefits on both glucose and energy homeostasis. So let's just go through these one at a time. I'm only going to have time to cover the ones that I've done work in. The first one to get the field started was changes in gut hormones. And that whole field of study started with a paper that we published in my lab several years ago in the New England Journal of Medicine. And it was reporting hormone levels of the newly discovered appetite-stimulating hormone ghrelin in human subjects. We found that ghrelin levels in people naturally surged right before every meal. Here's breakfast, lunch, dinner. And as soon as they began to eat, they would come down again. And that helps, along with a lot of other findings, implicate ghrelin as the long-sought mediator of ordinary mealtime hunger. We also found that when people lost weight, in this study and many others, with dieting or exercise or lots of other techniques, their ghrelin levels would rise commensurate with that and constitute a compensatory change. That implicated ghrelin as a participant in long-term body weight regulation and one of the reasons it's hard to lose weight. However, we found that in contrast to any other mechanism of weight loss, that achieved with in this case, gastric bypass and later sleeve gastrectomy was associated with very low levels of ghrelin, helping perhaps reduce people's appetite. And because ghrelin is pro-diabetic, compromised ghrelin secretion could contribute to an anti-diabetes effect. Now, since this paper was published, it's become very clear, even to me, that the role of ghrelin in the effects of metabolic surgery, if anything, is very, very small. However, I think this paper had a historic importance in helping people get started to think of metabolic surgery as an endocrine intervention. And that helped launch other fields of study, for example, this one, which remains very popular. Increased GLP-1 secretion as a mediator of some of the effects of metabolic surgery. It's an easy concept. Normally, when you eat, your food travels down through your intestine, and when it gets down to the bottom, it stimulates L cells there to produce several gut peptides, GLP-1, oxyntomodulin, PYY, which reduce food intake and make you feel full. In addition, one of those, GLP-1, helps stimulate insulin secretion, which is very sensible if you just had a meal. So it would stand to reason that if you created a shortcut for ingested nutrients to get down to the distal intestine faster and in a greater degree, skipping a few feet of intestine, and probably more important, the pylorus, you should hyperstimulate these peptides. And that's absolutely true. Here's some very early data from my lab showing GLP-1 responses to a standardized test meal in the lower bars with people before diabetes, before gastric bypass, and then the same individuals in lavender after gastric bypass. And you can see that gastric bypass augments the postprandial secretion of GLP-1 by about 30-fold. It's magnificent. That's true of all the L cell peptides I mentioned, and including GLP-1, which is associated with the expected insulin secretion stimulation that you would get from GLP-1. Now, our work in Ossapa pigs has shown that this mechanism of the augmented GLP-1 secretion after gastric bypass is not simply explained by a physical shortcut of nutrients to the distal intestine. It seems to be more complex. But whatever the mechanism of the GLP-1 effect, it's very strong and presumably helps underlie these findings. So what I'm showing you here are data from our Labs 3 study. And this was data acquired from frequently sampled IV glucose tolerance tests performed on 100 plus people, about 105 people, either at baseline or at 2 different time points after gastric bypass. The metric shown here is called disposition index, and that is a quantification of how much insulin is secreted under a glucose challenge, and taking into account or normalizing for the prevailing insulin sensitivity. Let's look first at the blue data. These are people with diabetes. And it was, by design, it was very mild diabetes. They had to have only one oral medication and still maintain an A1C between 6.5 and 7.5. Now, despite the fact that that is wimpy diabetes, note that at baseline, this disposition index is already in the toilet with very low levels of insulin secretion and sensitivity. Things get better when they undergo gastric bypass. 6 months later, there's a better disposition index, gets better still at 2 years for a respectable 150% increase in this measure of insulin secretion. Now let's look at the red data. That's people without diabetes. They either had pre-diabetes or were normal glycemic. When they have a gastric bypass, their disposition index goes through the roof at 6 months, further still at 2 years, for a magnificent almost 800% increase in this measure of insulin secretion. So these data, along with others, show you that the earlier you intervene with metabolic surgery in the diabetes natural history course, the better results you get. So is this story of enhanced GLP-1 stimulating insulin secretion the whole thing? And the answer is clearly no. Many people have found with genetic and pharmacologic experiments that take GLP-1 out of the equation, loss of function experiments, that GLP-1 only accounts for a small minority of the total benefits of gastric bypass on glucose homeostasis. So what else is going on? Now I'm just going to skip over some things quickly where I didn't participate directly in the research. There is a large volume of evidence contributing to the idea that favorable changes in bile acid signalings confer benefit on glucose and energy homeostasis. Similar story applies for changes in gut microbiota, as well as the uptake and utilization of glucose by the gut itself. And finally, favorable changes in iron metabolism that confer secondary benefits on glucose and energy homeostasis. This last one, I'm going to go into more detail because it comes from my own work. Favorable changes in GI nutrient sensing that confer benefits on insulin sensitivity. Now that my work in this got started or inspired by pioneering work by Francesco Rubino. Early on, he wanted to determine what was the effect of just bypassing the proximal intestine, similar to what a gastric bypass does, but not compromising the stomach at all. So he invented the duodenal jejunal bypass operation and found that this operation substantially improves or even eliminates diabetes in several rat models of diabetes, as well as in humans with little or no weight loss. So Francesco and I sat around some years ago and scratched our head and says, well, is this weight independent beneficial effect on diabetes because of enhanced delivery of nutrients to the distal intestine, maybe stimulating GLP-1, and or do you get some benefit of not having nutrients in the proximal intestine? So to explore this, we published a paper together comparing his operation with a variant of it shown here, where we maintained the distal intestinal nutrient shortcut, but got rid of the proximal intestinal bypass by allowing food also to go through the proximal intestine through the pylorus. And what we found in a rat model of diabetes called the GK rat model was that first operation eliminated their diabetes without any weight loss, and all the benefits were lost if we allowed food just to go back through that proximal intestine, even though the distal intestinal shortcut was still maintained. So encouraged by those results, Dave Flum and I got an NIH grant to study this in humans, and I'd like to show you our data on that. Now, for this study, we recruited people with severe obesity and type 2 diabetes. And at baseline, we characterized their glucose homeostasis phenotype in 3 ways. First, we did a standardized meal test, which quantified their gut peptide release. Then a frequently sampled IV glucose tolerance test, which is the gold standard for quantifying insulin secretion, and a hyperinsulinemic euglycemic clamp, the gold standard for quantifying insulin sensitivity. So all that gets done at baseline. Then they have gastric bypass. And for the first 2 weeks, they eat normally through the mouth, which means that food bypasses the proximal intestine, which for the most part is the duodenum. And then we find out what goes on. Now we know that at 2 weeks already, most people's diabetes will be improved after gastric bypass. And we're going to learn, is that primarily because of improvements in insulin sensitivity, secretion, or both? Now, the key part of the experiment. In the next 2 weeks, we feed primarily through a gastrostomy tube placed at the time of surgery, which routes food back through the proximal intestine, eliminating that bypass. And after 2 weeks of eating like that, we do all of our studies again and see if that changes. Finally, to control for the passage of time, the G-tube is removed, proximal intestinal bypass is reestablished, and after 2 weeks of eating like that, we redo all our tests. So every participant is studied in 4 conditions serially. First with duodenal nutrient passage, then exclusion, passage again, and exclusion again. To minimize confounders, we put together 2 major control systems. First, we wanted to try to limit the effect of weight loss, so we tried to clamp that at a fixed level by putting people on a 1,200 calorie a day diet for 12 weeks or 3 months before surgery, and trying our best to maintain them on that same diet for the duration of the postoperative follow-up, with the exception of a couple of perioperative days. Secondly, we know that people's diabetes is going to get better so fast after gastric bypass that even in this time frame, most of them will begin to shed their diabetes meds. We can't have that. So we tried to handpick our people to have diabetes, but be able to be safely removed from all diabetes medications for a 1-week washout period prior to each of the 4 testing sessions and not end up in the ICU. And we monitored their glucoses very carefully during that period and then rejected them if they went up too high. We lost a lot of good candidates that way. So this is a really difficult study to recruit and retain for, but each subject is studied in great detail and serves as his or her own control. And we have a lot of data, but I'm just going to show you the core finding. This is insulin sensitivity by hyperinsulinemic euglycemic clamp. Now, you don't recognize these units, but at baseline, it was very low. They were very insulin resistant. 2 weeks after gastric bypass with duodenal nutrient exclusion, we were successful at preventing weight loss, and yet we had a tripling of insulin sensitivity. How big a deal is that? Well, that's about what you'd find at a year or two after surgery if you did this study according to other people's work. Our work suggests that all the benefit occurs even before they lose weight. Now the key part of the experiment. For the next 2 weeks, we put food back through the duodenum via the G tube, and at that point, all of the benefit is lost. Despite the fact that at time point 3, they'd begun to lose a little weight, despite our best efforts to prevent that, which, if anything, should have increased their insulin sensitivity, and yet it was reduced when we ran through food back through the duodenum. Then we removed the G tube, reestablished duodenal nutrient exclusion, and we got all the good stuff back again. We had a lot of data that goes along with this and all supports this basic finding, but this is the core finding: a high amplitude, reversible increase and decrease in insulin sensitivity measured by the gold standard technique, independent of weight loss. So this strongly implicates the proximal intestine as an influencer of insulin sensitivity independent of weight change. Now, it may seem kind of heretic to think of the gut as influencing insulin sensitivity. We mostly think of it as a regulator of insulin secretion through incretins, but we're not the only group that's suggesting it does both. Tony Lamb's group at the University of Toronto has published a whole series of nature-level papers which have defined a neurocircuit whereby nutrient sensing in the proximal intestine activates a neurocircuit up the afferent vagus to the hindbrain, down the efferent vagus to the liver to influence hepatic insulin sensitivity in a way that's benefited by duodenal nutrient bypass. In addition to that neurocircuit, Geltrude Magroni has published a paper where she finds that in muscle, the canonical insulin signaling pathway shown here is impaired by some as yet undiscovered protein that's secreted by the intestines of rats with diabetes, but not those without, which through an mTORC2 dependent pathway inappropriately serine phosphorylates AKT, a key downstream kinase of insulin, and prevents it from being appropriately threonine phosphorylated by insulin, gumming up insulin signaling. Now, this notion that the intestine secretes one or more pro-diabetic factors in the diabetes state forms the business plan behind Fractal and Endogenics, which are 2 companies that have developed endoscopic methods to ablate the duodenal mucosa and silence this factor or factors through different mechanisms, thermal ablation or irreversible electroporation. And in advanced clinical trials, as well as now the beginning of marketed products, they are showing major improvements in diabetes with no weight loss whatsoever. Similarly, it seems as though you can silence this pro-diabetic factor or factors from the proximal intestine by simply putting an endoscopically placed proximal intestinal sleeve and creating a bypass of the duodenum similar to a gastric bypass. This is being promoted by companies like GI Dynamics and Metamotics there in India, and they are again showing tremendous effects on glucose homeostasis before and out of proportion to the relatively minimal weight loss they sometimes can cause. So weight loss, as well as these multiple weight-independent anti-diabetes mechanisms, contribute to the profound effect of surgery on diabetes. Let's switch now from these more scientific discussions to the clinical discussion of where does metabolic bariatric surgery fit in diabetes care now, especially in people with only mild obesity. Well, for 30 years, the placement of bariatric surgery in clinical care has been dictated by a set of consensus guidelines from the NIH in 1991. They limited surgery to people with severe obesity and a BMI over 40, or moderate obesity and a BMI of over 35 with a complication like diabetes. Now, these guidelines, as impactful as they've been, were flawed in the first place, and they're now incredibly outdated. But they have served a useful purpose of standardizing care throughout the world. So now we can say from 3 decades of practice like this and great numbers of studies that for this severely obese population, metabolic bariatric surgery is highly efficacious, safe, and cost-effective. Despite all that, however, Until just recently, you would not see bariatric or metabolic surgery mentioned anywhere on this all-important treatment algorithm for treating diabetes that gets put out every year by the American and European Diabetes Associations. Why is that? I would submit that the reason that it does not come around until recently is that until recently, there's been a paucity of relevant level 1 evidence from randomized controlled trials directly comparing surgical versus non-surgical approaches to diabetes. But these are really hard to do, I can say from experience. Most people are not willing to be randomly allocated into treatment options as diverse as a major operation versus diet, exercise, and medications. But despite those Herculean operational challenges, my group and others have now filled this knowledge gap. I'm going to summarize quickly just the 2 trials where I've been a principal investigator. The first done here in Seattle is the Crossroads trial. It was an RCT of surgical versus non-surgical approaches to diabetes in patients with a BMI of 30 to 40. So some of them were below the traditional threshold for bariatric surgery. They were randomly allocated to get a gastric bypass and standard care or a super aggressive medical lifestyle intervention. It consisted of aerobic exercise, a low-calorie fat diet, and state-of-the-art diabetes medication treatment. Now, the thing that distinguishes Crossroads from other similar RCTs in the space is the rigor of the lifestyle intervention. It was based after a look ahead, only then even more so. It consisted of at least 45 minutes of heavy aerobic exercise per day, at least 5 days a week, largely supervised by a personal trainer in this beautiful dedicated research gym. In addition, everybody had a personal dietitian. They had weekly group sessions, and get this, we asked them to record their food intake, everything they buy, every bite of food they ate for a year, and put it into their tablets and their phones and their computers, and it floated to the cloud. And if you had cheesecake on Tuesday, by Tuesday night, your dietitian knew about that. This was not meant to be something you could easily translate into the world. It was meant to answer the question, under the best possible circumstance, can diet, exercise, and meds match the power of gastric bypass on diabetes? Our randomization scheme was successful. The surgical and lifestyle medical groups were equivalent in everything we measured at baseline, with one exception. Presumably by chance, it happened that the surgical group had nearly twice as long a duration of known diabetes compared to the medical group, which, if anything, should make it harder for surgery to win in this competition. However, despite that conservative bias against surgery, on the primary endpoint of diabetes remission at 1 year, surgery won hands down, achieved in 60% of the surgical patients versus only 6% of the lifestyle medical intervention, despite the rigor of that medical lifestyle intervention. Now I'm going to skip on to the next trial that I've been a PI on. And this one addresses the question of this. If you have an operation that's an intervention that's so powerful against surgery, like gastric bypass, including in lower BMI people, why not consider its usage in populations that tend to get their diabetes at low BMIs? And you guys there in South Asia know that that's the description of your country. So some years ago, I entered a very rewarding collaboration with Shashank Shah and his colleagues in India to do the COSMID RCT. So COSMID is a randomized control trial of surgical versus medical lifestyle intervention among patients with diabetes who are of Asian descent, 80 of them. Pardon me, South Asian descent, done in India. They were randomly allocated to get either a gastric bypass and standard care or a moderately intensive medical lifestyle intervention. So that consisted of monthly face-to-face counseling, exercise advice and a paid gym membership, a reduced calorie and low-fat diet, very liberal use of prescription weight loss medications, and again, state-of-the-art diabetes medication usage. The thing that distinguishes COSMID from other similar trials is the large number and percentage of people with very low BMIs. So nearly half of our population had a BMI of only 25 to 30. More than a third were in the 30 to 35 group, and only a handful were above 35 to in between 35 and 40 in the standard bariatric surgery area. So let me show you now our 2-year data. So the first study was 1 year, this is 2 years. Eerily similar to the results in Crossroads, the achievement of the primary endpoint of diabetes remission, in this case at 2 years, was exactly the same, 60% in the surgical group versus only 2.5% in the medical lifestyle group. We defined remission as being, in both cases, off of all diabetes medications with an A1C below 6.5. Now, many people have come to believe that it's not fair to do an RCT like this where the primary endpoint is remission, because you have to be off your diabetes medications entirely to achieve that goal. And medicines are the main tool that the medical lifestyle group has to get to its glycemic targets. I have come to believe that that's true. So let's just look at A1C with or without medications. We were pretty proud of what we did in the medical lifestyle group. They dropped from an A1C of 9.5 down to 8 and stayed there for 2 years. So touche for the boots on the ground who achieved that. However, the reduction in A1C was much greater at every time point throughout 2 years in the surgical group, dropping from about 9.5 to about 6.5 and staying there for 2 years. Results were exactly the same for fasting glucose. You have to look at these in the context of medicines used to lower glycemia. So again, we were proud of what was accomplished with the medical lifestyle group. While lowering their A1C, they also lowered their diabetes medication usage, which means that the diet and exercise must have been useful. However, the medication reduction again was much greater all throughout the 2 years in the surgery group. Now we performed a subgroup analysis that I think is very informative. We asked the question, in the surgical group, were the results any different between people who started out a bit heavier within our group versus lighter in our group? You would expect the heavier people to lose more weight. So we subdivided our people into those whose BMI started at baseline either above or below the median, which was 30. As expected, the heavier half of our people shown in the closed circles lost more weight than the lighter half of our people shown in the open squares. And it's a big difference. The heavier half lost almost 35% of body weight, and the lighter half only a little more than 15%. Despite that huge difference in weight loss between the heavier and lighter people, the reduction in A1C was identical across the entire 2-year period, as was the reduction in glucose-lowering agents. Why do I find that important? Well, to me, this says that the weight-independent mechanisms of gastric bypass surgery are not just bit players, but strong, powerful actors that can render equivalent reductions in A1C despite very large differences in body weight change. So here are the take-home messages from COSMIC. This is the first randomized trial of surgical versus non-surgical care for diabetes in Asian patients. It has the largest number of patients with a BMI under 35 and the lowest threshold for BMI ever studied in such an RCT. And it shows us that the benefits of metabolic surgery for diabetes that have largely been shown in heavier Caucasian populations appear to apply also to lighter, lower BMI Asian populations, at least South Asians. And it remains to be demonstrated whether this is going to also hold up in East Asia. So how do our Crossroads and COSMIC trials compare to other RCTs of metabolic surgery versus meds lifestyle for diabetes? To answer that question, I'm showing you a forest plot that we developed for one of our Diabetes Surgery Summit projects. I'm going to tell you about those in a second, showing the results from the 12 existing RCTs of surgical versus medical lifestyle approaches to diabetes. And what you can see is that in all 12 cases, a variety of different metabolic surgery operations was always better than any known medical lifestyle intervention, including some very rigorous ones like our Crossroads, at the primary endpoints of these studies, which had to do with glycemic control. Now, it looks like one of them here in the middle isn't statistically significant. That was mostly a banding study, and it became statistically significant later in a secondary publication with longer follow-up. I like this graph because I asked the statistician to organize it in the order of ascending baseline BMI in the study cohorts, from the lightest cohorts at the top to the heaviest at the bottom. So the breakpoint for the average BMI of the study cohorts being above or below 35 is shown here, 35 being the traditional NIH standard for the ability to do surgery in people with diabetes. If you look at results above and below that line, they look the same. And that's statistically true. So this provides us with a rare level of evidence called level 1A, which means derived from a meta-analysis of only randomized trials, that tells us that the degree to which metabolic surgery is superior to any known medical lifestyle intervention for diabetes glycemic control is equally powerful whether your BMI starts above or below 35, strongly calling into question the use of that threshold as a criterion for surgical selection. So what we can say from the universal results of those 12 RCTs is very clearly that metabolic bariatric surgery is more effective than any known medical lifestyle intervention for weight loss, glycemic control, especially diabetes remission, improvements in other cardiovascular risk factors with acceptable complications for up to 10 years, and with results similar above or below BMI of 35 at baseline. So, cool, the glycemic question is answered. Surgery is better. The trouble is, glycemic control is a surrogate endpoint. Very few people actually die of high blood sugar per se. They die of the long-term complications of that on end organs over decades. So let us now turn to the impact of metabolic surgery on microvascular diabetes events. Now we largely move, except for the MOMS trial, away from the area of RCTs and into the domain of large long-term matched cohort studies. So here's an example. This is a paper published by my colleague in Seattle, David Arterburn. It's a matched cohort study of over 15,000 patients who either did have metabolic surgery or did not, and importantly, were beautifully well matched at baseline for everything you would care about. You can see that the people who had surgery enjoyed about a 50% reduction in microvascular disease events compared to their matched non-surgical controls. And that was true for retinopathy, nephropathy, and neuropathy. This is just one good example of the kind of study in this space. I am aware of at least 13 other studies that have all shown the exact similar findings. How about surgery and its effects on macrovascular events? That would be heart attacks and strokes. Again, I'm going to turn to an example of this kind of study done by David Arterburn in Seattle, published in JAMA. This is a matched cohort study of over 20,000 patients who either did have surgery in the orange or did not in the blue, and again, were very well matched at baseline for anything you would care about. You can see that over a period of 7 years, the surgery people enjoyed a 45% reduction in heart attacks compared to their matched non-surgical controls. They had 52% fewer strokes. Putting those two together, they had a reduction of all macrovascular disease events of 48%, and then a stunning reduction of all-cause mortality by 70%, the added benefit coming from reductions in cancer deaths. This is just one good example of the kind of study that's done in this area. I'm aware of 8 similar studies, all with analogous findings. Now you have to weigh these benefits against possible risks of surgery. All operations have their risks. Metabolic surgery is no different. By far, the most common complications are micronutrient deficiencies, which are totally easy to avoid if you just take your supplements, but in the real world, a lot of people don't. For me, with my patients, this pertains to the question they are more commonly asking. Hey, doc, how likely is it that I'll die on the table? So this shows you a study from the American College of Surgery of over 70,000 patients. And it shows you the chances of dying within 30 days from any cause after various different operations. You can see down here at the bottom, laparoscopic gastric bypass has an all-cause mortality rate of about the same as an elective knee operation, well below appendectomy or cholecystectomy. More recently, and with larger numbers, the beautiful MBSA QUIP database has reported on more than 141,000 patients a 30-day operative mortality of gastric bypass at 0.2% and sleeve gastrectomy at 0.1%. Once again, that's about the same as the likelihood of dying from elective knee surgery. This is the most important question. Hey, doc, am I likely to live longer if I have this operation or if I don't? So to address the all-important question of mortality, I'd like to turn to our new study, which we published in May in The Lancet. So I'd like to say that I am the shared or co-first author on this paper, but I just want to have a quick shout out to the guy actually listed here first, Nicholas Sin. He's a brilliant young scientist I'm sure we're going to be hearing more from, as well as the senior author, Asim Shabir, a trusted and dear friend and colleague for a long time. So for this paper, we did a longevity meta-analysis of metabolic surgery. It was very high quality and rigorous, and it used individual patient-level survival data constructed from prospective controlled trials and high-quality matched cohort studies, all of which compared people who underwent metabolic surgery or did not and were well matched at baseline. That had to be a criterion for inclusion in this study. This shows you our PRISMA acquisition diagram, in which we went from a large number of potentially analyzable studies to a filter through our filter of quality control to a smaller number that we actually analyzed. All told, we looked at about 175,000 participants, including a 1.2 million patient year follow-up period. Our core finding is shown here. This is the cumulative all-cause mortality over as many as 30 years of people who either had metabolic surgery in blue or did not in orange, and importantly, were beautifully well matched at baseline. You can see that the folks who had surgery enjoyed a survival benefit, which was statistically significant at 1 year and then just got bigger and bigger and bigger for 30 years. So to put that finding into summary words, compared to matched non-surgical controls, metabolic surgery was associated with a decrease in the hazard rate of death of 49.2% and an increase in the median life expectancy of 6.1 years. We did several subgroup analyses. The most important of them is this: people who started with diabetes or not. If you look visually, it seems like the survival benefit in the surgical group compared to matched non-surgical controls is greater if you had diabetes than if you didn't. And that was true. Again, summarizing this in words, compared to matched non-surgical controls, metabolic surgery was associated with a decrease in the hazard rate of death of 59.1% among people with diabetes and 29.6% without diabetes. Surgery increased the median life expectancy by a whopping 9.3 years if you had diabetes and a respectable 5.1 years if you didn't. In terms of the number needed to treat with surgery to prevent one death over 10 years, that was a mere 8 if you had diabetes and 30 if you didn't. Now, if you're used to NNT data, both of those are very favorable for surgery, but it clearly shows you how much more survival benefit you get with metabolic surgery if you have diabetes than if you don't. This graph is a little hard to understand, but it shows our estimates of the number of life years gained globally with every 1% increase in the actual usage of metabolic surgery among qualified candidates, and the x-axis are with and without diabetes. To make this easier to understand, in summary words, we estimate that with each 1% increase in the actual usage of metabolic surgery among qualified candidates, we would save about 12 million potential life years worldwide. So, in most industrialized nations, the actual percent of people who qualify for surgery who have it, metabolic surgery, is a little less than 1%. So if we just took that to a little less than 2%, we would save about 12 million people every year in the world. So I submit that we now have relevant evidence from many RCTs and large long-term prospective studies with harder outcomes to inform and update policy. And that has been a major goal of the Diabetes Surgery Summit's series of objectives and projects that I've been working on since 2007, along with Francesco Rubino and Phil Schauer, the other leaders. One of the main goals of this is to update the standards for use of surgery. And a few years ago, we firmly put for the first time metabolic surgery in the diabetes treatment algorithm for overall diabetes treatment that gets published every year by the American Diabetes Association and its European equivalent. And it's remained there ever since. The group has agreed with high consensus that metabolic surgery can be considered to treat poorly controlled diabetes in patients with a BMI down to 30 or 27.5 for Asians. It's not a very big numerical change coming down from 35, the prior standard, but it does include a lot of people in the world. And we figure it's approximately 300 people with diabetes who could benefit or could consider now metabolic surgery as an option who wouldn't be able to do so by the old NIH standards. That is to say, if our standards are taken up and adopted through the world. So I'm going to show you the countries in the world that I am aware of that have adopted DSS guidelines in lieu of the old NIH 1991 standards, and at least at some level as a national policy. Bless their hearts, the first was Singapore, then Saudi Arabia, then, very importantly, India and China, where most people in the world with diabetes live, also Taiwan, Australia, the United Kingdom, Chile, Argentina, Brazil, the Philippines, Thailand, Malaysia, Indonesia, Japan, South Korea, and Hong Kong. Oh, and just recently, we added Switzerland to that group. How about my country? Well, some companies, an increasing number of US companies large enough to self-insure, have switched over from NIH to DSS, Diabetes Surgery Summit. Very importantly, the largest health insurer in the world, United Health Group, about a year ago changed its standards, and they now use Diabetes Surgery Summit standards to guide the payment choices of who can get surgery and who can be considered a candidate. Medicare, Medicaid are actively considering it. And for me personally, very importantly, all Department of Defense and National Veterans Administration hospitals now use DSS guidelines instead of NIH. That's important for me because I work at a VA hospital. So on Monday, if I had a patient who had badly controlled diabetes and a BMI of 28 and he was Asian, I could consider him for metabolic surgery. Or if he was not Asian, he could be considered with a BMI as low as 30. Now, despite all this evidence of efficacy, cost effectiveness, and safety, and the change in policies I've just shown you, the actual usage of bariatric metabolic surgery remains incredibly low and stagnant. To put some numbers on that, This was a chart we put together for one of our Diabetes Surgery Summit projects recently. It shows you the percentage of people who qualify for metabolic surgery in various countries who actually have it. In the course of a lifetime, that number is 0.96 in the United States and 0.86 in the 41 countries shown here. That number really hasn't changed in the passing years, despite all the evidence base to show the things I mentioned. So we gathered together an international consensus conference to try to come up, this is another Diabetes Surgery Summit project, to try to come up with an identification of barriers to the uptake of metabolic surgery. We identified many, but I'm just going to concentrate on one. And that is an entrenched and enduring form of obesity stigma, which tends to make afflicted individuals feel guilty about their own problem and as such not seek interventions of any kind. No, they don't even seek help from medicines or surgery. So we published in this joint international consensus conference statement for means to try to end the stigma of obesity. And we were very pleased that less than a year ago, it was published in Nature Medicine, and even more pleased that it's been formally endorsed by more than 100 medical, scientific, academic, and political organizations, as well as peer-reviewed journals, including all the really top ones. In the last 2 minutes, I'm just going to quickly close with addressing the question that's very timely of how should we prioritize who gets metabolic surgery in the time of COVID? To address this, it was again a Diabetes Surgery Summit project. A bunch of us got together and published a paper several months ago in the Lancet Diabetes and Endocrinology. I'm the senior author on that. And in a nutshell, we put together a very carefully constructed algorithm to use for deciding who is the most high priority versus less priority person for getting metabolic surgery when you can get access to it in the COVID era. Now, it's a very detailed thing and shown here. I don't imagine you're going to appreciate this, but it is published. You can look up the details. But I want to close with just a summary statement. It is our impression that after the COVID pandemic passes and you're beginning to restart elective surgeries and you're dealing with backlogs of patients who accumulated in limited access, priority should be given to patients based on their burden of diseases, metabolic diseases, likely to be ameliorated postoperatively and likely to cause harm if they're delayed, and not on BMI. So the woman with a BMI of 50 and no comorbidities should not be, she should be put to the side compared to the man with a BMI of 40 less, but diabetes, hypertension, and dyslipidemia, because the guy, if you delay him, is possibly going to die, whereas the woman can afford to wait. And the most important thing I want to say about this project is that although that triaging algorithm is particularly germane after the COVID pandemic lets up and we begin to get access to surgery again, there is no reason why it could not be clinically meaningful, used to prioritize patients long-term into the future, because the principles still apply. I've had the privilege of working with many talented people at the University of Washington over my career, as well as many cherished colleagues abroad, including many in India shown there. I thank them all for their hard work and you for your kind attention. I will stop sharing my screen now. And I think we're right on time.
Yes, sir. Thank you, Dr. David Cummings, sir, for your for sharing your extensive knowledge regarding various trial, bariatric surgery, and its impact on diabetes, cardiovascular events. I would also like to thank all the panelists for your wonderful lecture, where you have covered an important topic regarding the obesity, nutritional approach, psychological aspect, physical exercise for the weight loss, as well as the novel therapy and interventional option for weight loss. Now we will move further for our next session of question and answer, and we will have a panel discussion. So if any one of the participants have any doubt, any question, any query, just please mention the question in the chat box along with the panelist whom you would prefer to answer that question, and we will try to help you regarding that. So we have a question from Dr. Vinita, and her question is: obese individuals often have knee and ankle joint arthritis. So which exercise would you recommend in these cases? So these questions are open for all the panelists, so they can answer this thing.
So I'm not going to try to answer which exercise, because that's out of my field of expertise.
Yeah.
But
I think Dr. Mallar would answer this question.
Could I just say one thing, because it pertains to my second to last slide? Metabolic surgery to be used to allow some other operation that you need, like a cabbage or an organ transplant or a knee replacement, that's considered a high priority situation and should go in the front of the line over other people in a limited access situation. Now I'll yield the floor.
Yes, yes. So I would request Dr. Mallar to answer this question, where the query is obese individual often have a knee and ankle joint arthritis. So which exercise would you recommend in such cases?
Don't always have, it's again, you're getting into diagnostic parlance again. You first start with the diagnosis. They have to start exploring what they can do. So they have to first lose 10% weight, go to the gym, strengthen the tendons, strengthen the ligaments. The biomechanics will change. As they lose weight, the center of gravity will change. That same ligament which was getting strained will no longer get strained. So just, avoid using terminologies like arthritis, because then they get an excuse to do nothing.
Yes.
So don't get diagnostic with obese people, and they'll Google so much, he'll convince you that he has everything. So the better thing is send him to a gym, get a physiotherapist home, one step at a time. Just avoid diagnostic terminologies with them. Okay.
Yes, yes.
If nothing else, swimming and physiotherapy is the best for 3 to 6 months while they lose weight. Then they can do everything.
Okay, sir. Okay, sir. So next question is by Dr. Komal. Her question is, what is lifetime restriction after the bariatric surgery? So after the bariatric surgery, is there going to be any restriction as such, which the patient will have to follow a lifetime?
Well, they have to take nutritional supplements for lifetime. I think that's the most obvious answer. In the United States, at least, the usual practice is that after a gastric bypass, they're prescribed specialized multivitamins that are designed for people with bariatric surgery. They're enhanced in some of the things that are most likely to be deficient. These are not overall calories, but micronutrients and minerals. In addition, especially in places that are cloudy like Seattle, we prescribe an enhanced form of vitamin D as a pill, a chewable pill. And those are taken for life because the anatomy is for life. For reasons that I've never quite understood politically, it's also recommended that people who have sleeve gastrectomy take these for life as well. I don't know why that is, since the pylorus and the entire digestive system is still intact. But my guess is that the American Society for Metabolic Surgery, Metabolic and Bariatric Surgery made that rule just to make it easy to follow for everybody. They're supposed to take protein supplements for 6 months, but that's not a lifetime thing. That's just when they're in active weight loss. And if their operation imposes a restriction on gastric volume, like gastric bypass, and makes a very small residual gastric capacity, they should always be attentive to eating kind of slowly and chewing well.
Neeraj sir, would you like to add another point, any restriction after a bariatric surgery?
No, I absolutely.
Go ahead.
Yes.
Go ahead.
So I absolutely agree with Professor. What happens is immediately after the post-operative period, patients can have some amount of challenges in their quantity and volumes, but over a period of time, their pouch adapts and they have been able to eat adequate. So that has been never an issue. They are required to take long-term, probably lifelong nutritional supplements, which is a mandatory. The biggest challenge we face here is a regular follow-up. Once they start losing weight and come to a plateau, they tend to lose their follow-up because their life has become now better. And that's where we try and chase them and insist them on doing few investigations very regularly, especially once in a year, to monitor their nutritional deficiencies and if they need correction. The other modification, which I have seen quite often in patients significantly after the years of surgery, is that their diet pattern over the years also changes. Indians being a lot of carb focused people, they tend to go back to their carb rich diet and they face dumping syndrome. And then they come back to us where we have to counsel them and educate them about the role of carbs in their diet and how it should be balanced with the protein intake.
I also forgot one thing. This is an important warning. It was discovered several years ago that the incidence of alcohol abuse disorder goes up significantly after gastric bypass in particular. And The reason for that, there's two of them. The major one is that the pylorus is removed from digestive continuity. So normally, if you're in an intact GI system, when you drink your alcohol, most of it sits in the stomach for a while and then oozes slowly into the absorptive surface of the intestine. So after surgery, beforehand, your alcohol levels go like this after you eat your drink. When the pylorus is gone and the food drops straight from your mouth into your bloodstream, the same glass of wine over the same period of time causes a blood alcohol that goes like this. It's a huge spike, and the peak level is about 4 times higher than before surgery for the same alcohol consumption. The overall area under the curve is not very different, but the peak level, even if it's short, is what makes you feel drunk. And when you're drunk with what feels like 4 glasses of wine from only one, maybe you lose your restraint and say, let's have another. And now you feel like you've had 8, and now you're down a really bad path. So the bottom line is, for people who have alcohol use issues or were once in trouble, or my biggest one would be the person who drinks two drinks every night. Not really a problem, but every night. I'd be concerned that person might turn into alcohol abuse, and I would prioritize a sleeve gastrectomy and counsel them to drink slowly. It's not that they can't drink, you just got to sip it.
Next question, it is open to all panelists, where the question is by Monica, and her question is, please explain the role of mTOR in relation to calorie restriction, exercise, and also its effect on the brain. So is there any role of mTOR in relation to caloric restriction and exercise?
I defer to the calorie restriction and exercise experts.
I think it's related to the mTOR gene she's speaking about.
Is she speaking about mTOR or she's speaking about mentor?
I think it's targeted rapamycin is what she's talking about.
So may I take that question?
Yes, sir. Sure.
So we are all aware that mTOR stands for mechanistic target of rapamycin, and we know that many studies have shown that if you have more mTOR, it has an effect on aging. And if you pharmacologically inhibit mTOR, there are different types of mTOR, but if you pharmacologically inhibit mTOR C1 signaling, that can lead to increased lifespan. So this is one side of the story. So that's one side of the story which says that mTOR inhibition increases lifespan. Now, the second part of it regards to calorie restriction. Now, we know that one of the ways by which calorie restriction works is that it switches on some of the good genes and switches off some of the bad genes. So there have been some papers which have looked at the effects of calorie restriction on liver mTOR signaling, and they have found that restricting the calories has some effect on inhibiting the mTORs, and that inhibition of mTORs might be directly or indirectly linked to lifespan. So that might be one of the ways by which calorie restriction might promote longevity. Now, these are very early studies, very basic studies, and we need more research into that. So many other medicines, including metformin, these are all some of the medicines that have an effect on the mTOR, because metformin is also known to offer zero protection, not zero protection, zero protection, like as in geriatrics. So it's supposed to increase longevity, and this is probably one of the ways in which it may work. So this is very early research, and this is what I can talk from a very general point of view.
Okay. Next question is by Dr. Sagar, and it is how safe is a gastric balloon procedure?
Every procedure has its own pros and cons. Overall, gastric balloon procedure has no challenges or issues. There are some untoward incidences which have been mentioned in the literature, which include spontaneous rupture of gastric balloon or difficulty while retrieval of gastric balloon. There are few incidences where balloon has to be required to be removed in a quite earlier period after the insertion because of the intolerance from the patient side. Besides these three complications, overall the balloon is tolerated pretty well. but the role of balloon is limited to only people having an excess weight in the range of 15 to 20 kgs.
Dr. David, sir, would you like to add any point regarding the how safe is a gastric balloon procedure?
It's my impression that balloons are very safe. The only question is how effective are they in the long term? I think as they've been developed through the years, they've struggled more to try to demonstrate long-term efficacy rather than safety, which is pretty fine.
Okay, sir. Next question is by Dr. Shraddha. Question is, do the benefit of metabolic surgery extend beyond 5 years or longer?
Oh yeah. So the longest data we have in randomized controlled trial is from 2 trials that have been published recently at 10 years. Well, I'm sorry, actually, Stampede is not yet published. They're holding on to their data, but I'm aware of the data. And then the Mingroni and Rubino paper was published in Lancet this year with 10-year follow-up, a randomized trial of metabolic surgery versus medical lifestyle intervention. And the benefit of surgery over medicine lifestyle remains for at least 10 years. The benefit of surgery compared to itself earlier, it wanes over time. The best database for asking questions about that is the Swedish obese subject study, which has follow-up now to 30 years. And what you see is that diabetes remission rates, they're maximum at a year, and then they begin to decline over time, and weight is regained to some degree. In the largest studies, in terms of weight loss, roughly speaking, with modern operations, you lose about a third of your body weight. So if you're 300 pounds, you go to 200 pounds. That's between 1 and 2 years. Between 2 and 5 years, you'll regain some of that and stabilize around 30% body weight, or maybe minus 28%. And then it just seems to be stable with the modern operations, not gastric banding. That's different. Gastric bypass and sleeve gastrectomy seems to last for as long as we've studied, which is out to at least 30 years. Diabetes remission, the best study for that comes from Arterburn again. It was a study of 13 years, and it was about diabetes. He found among 4,484 people who had gastric bypass who all had diabetes. The remission rate at 1 year was about 70, which is usual. And then he asked the question, what % relapses over the 13-year follow-up? And it was about a third of the ones who had remission would relapse over that period of follow-up. The press was very negative about that. They said, well, we thought you told us this cures diabetes, and now you tell us it relapses. They were kind of unfair because they didn't understand, or they didn't pay attention to the fact that even in those who recurred, the median disease-free time period was 8.5 years. And given what we know about the benefits long-term on reductions in macrovascular events like heart attacks and strokes, from even just being in tight glycemic control for a few years versus not, this is from UKPDS study or the DCCT edict, that legacy effect, imagine the benefits of having no diabetes for 8.5 years. Moreover, 2/3 of the people who remitted stayed in remission for 13 years. So there is some relapse, but it's, you have a really good period of time. Even if you are going to relapse, you're going to have a good time of disease-free interval, and most people will keep disease-free as long as we measure.
Okay.
And again, I'm not talking about gastric banding here. Banding has fallen off the face of the earth because it doesn't do well long-term.
Dr. Ashutosh,
Yes,
there are some questions in the chat. In addition to the chat box, there are some questions in the question and answer session. Some questions on diet and physical activity. So
yes, sir. Yes, sir.
Let's take those also.
Okay. So there is a question by Dr. Milind Kumar, and his question is, he is an occupational health physician, and this question is for Geeta ma'am, and his question is, please explain ideal lunch plate to light work and heavy work employee.
Okay, so the lunch plate, generally a standard lunch plate, we all know is 50% vegetables, which is complex carbohydrates, 1/4 is proteins, and 1/4 is your grains, which is your cereals and Indian context, chapatis and rice. So this is an ideal lunch plate. What changes is calorie requirement and the macros contribution towards this when it comes to the lifestyle. A sedentary lifestyle is typically a person who hardly, according to the data, walks for 3,000 to 5,000 every day or sits for more than 8 hours every day. So we all say that look at a 1,500 to 1,800 kilocalorie goal. So it's half vegetables, 1/4 proteins in an Indian pulse or lentils or non-veg, and 1/4 of carbs. which is chapati, rice, a potato, a starchy vegetable. But when it comes to a heavier lifestyle, we need to understand what kind of heavy lifestyle, because now with mechanization, we really don't have a very heavy way of looking at calorie requirement. So the definition of heavy needs to be highlighted. The plate remains the same. What changes is the calories. Maybe if the physical activity is very high, if the meds are very high, if the person is working heavy with a heavy intensity work there for 8 to 9 hours, then the calories go to 3,000. We look in athlete diet. We can look at a person who's into a very heavy physical activity. The calories change to 3,000, and that the plate can look like the vegetable portions of 50% and one for carbohydrates. The carbohydrates can become, and vegetables both can become 3/4, and then the rest what is remain is protein. So the calorie changes from energy point of view. 70% of calories come from carbohydrate because they are the major source of giving you fuel. The protein remains the same. So 70 is a combination of the grains and vegetables. This is how the plate will look.
Next question, which is already being answered, the role of gastric artery embolization intervention. Is there any role of gastric artery embolization for the obesity, for management of obesity?
Well, it's a very emerging area. And as Dr. Neeraj showed some slides, there was a BEAT study which talked about embolization of the gastric artery. And, by embolizing the gastric artery, you embolize the fundus of the stomach, reduce ghrelin production, and the weight loss in the BEAT study was at the end of 12 months, about 8% of excess weight loss. It's a radiological procedure. There are said to be very, very little side effects, but on the other hand, this BEAT study also showed there were multiple little gastric ulcers that turned up, but all these ulcers got better at the end of 3 months. But let me confess that this is only from my reading of the literature, and we'll be privileged if Dr. Cummings or Dr. Raite has anything to share on this area. Very emerging area.
It is emerging. It's experimental, and I don't know much about it, but I would say that 8% of excess weight loss is pretty small. Now, excess weight loss is a terrible metric because it depends greatly on how heavy you are in the first place. So if a guy with a BMI of 26 loses a particular amount of weight and somebody else with a BMI of 50 loses the same amount of weight, the guy with a BMI of 26 will have had 100% excess weight loss, and the guy with 50 will have had like 3%, yet they've lost the same amount of weight. So, but in any circumstance, excess weight loss of 8% is pretty damn mild. It may have some role in the future, but it would, in order to be able to beat out semaglutide, it's going to have to do better than that. I'm using semaglutide as an example because most people would prefer to use medicines than any intervention. And now that semaglutide is causing 15% weight loss, and that's total weight loss, it's the metric to beat for interventions nowadays.
Dr. Ashutosh, may I just ask one more question to Dr. Cummings and Dr. Raite that pertains to this new therapy, this duodenal resurfacing therapy, and there have been whispers that it's going to get approved or approval or approvable and imminent and all that. What's your view on that?
I think duodenal mucosal resurfacing is very fascinating, and the fact that it works supports the notion that there is something pro-diabetic that's being released or made by the proximal intestine, which is contributing to diabetes in people with diabetes. It's hypothesized that this is a pro-diabetic factor of factors that are normally liberated in a regulated manner to prevent postprandial hypoglycemia, but become excessively excreted in diabetes and contribute to pathogenesis, like glucagon. So you silence them with duodenal mucosal resurfacing. For the group who doesn't know that, there's an endoscopic method where you ablate the mucosa of the duodenum, and then it regrows with what appears to be healthier tissue, at least for a while. It can be done thermally with a hot water. That's Fractal's approach. And I think the better approach is by endogenics, which does it by irreversible electroporation. They both seem to be very effective at glycemic control, and they're very safe. In terms of the availability, the Fractal product is now for sale in the UK. They've finished all their pivotal trials and have started to market. I have no idea how long it's going to take to get to India. It would be an appealing thing for people in India, where they're worried more about their diabetes than their weight in many cases. And it's a one-time fix. I think that it probably isn't going to last forever, because the mucosa is a very plastic tissue. I think you might be expecting 1 or 2 year effects, and then you do it again. But for some people, let's say they do it every 2 years, it's a 30-minute procedure. Some people would rather do something for 30 minutes every 2 years than take a pill every day. The reason I'm worried a little bit about Fractal's product is the thermal ablation. They're more likely to cause necrosis, which is more likely to cause scarring. And if you do it over and over again over several, some decades, I would be worried you get strictures. Endogenesis product, which is not nearly as well developed, but it's got a lot of potential with irreversible electroporation, that causes basically a lot of holes in the cells that create calcium fluxes that eventually lead to apoptosis. So over several days, you have programmed cell death, and that's not going to be nearly as inflammatory or scar forming. So it's probably got a better chance of being able to do it over and over again without causing scarring.
Thank you, sir. So next question is to Dr. Mallar, sir. And the question is from Ajay. So his question is, how much would a typical comprehensive weight management program cost?
I think that's a question for somebody other than me.
Dr.
I think
Mallar,
we
sir.
can go to the next question, maybe.
Okay. Yeah. Next question is, what is fatty thin? That's like a funny question. What is a fatty thin?
So I don't know. It's a very tough question, but I think this may attribute to the article in Lancet, which talked about the thin fat Indian. I mean, that's so rather than fatty thin, this might refer to the thin fat Indian. It might, of course. And if the person asking the question has another interpretation of this, he or she can put it up and we can look at it. But this is a picture of Dr. Yajnik, who is indeed from our own city of Pune, with Dr. Yudkin sitting together. Both of them had, the same height, weight, same BMI, but the amount of fat for the same BMI, the amount of abdominal fat or visceral fat in Indians is much more. So this might refer to the thin fat Indians, because we as Indians ethnically are thinner, but we might have more abdominal fat. And therefore, the cutoffs for BMI for various bariatric procedures or pharmacotherapy or for cardiovascular risk protection are much lower than in Western countries. And Dr. David Cummings did show some data on Asians also, and Dr. Veda also did mention that. So, Dr. Cummings, your views on bariatric cutoffs for Asian Indians, and you have an Asian community in the US. Do you apply that to the Asian community as well in the US?
Oh, yeah. Well, I mean, I'm one of the leaders in the Diabetes Surgery Summit projects, which are designed to try to update and optimize criteria for metabolic surgery, and a major focus on trying to expand the indications for people with lower BMIs for their diabetes. And so we would say that person of Asian descent, whatever your cutoff is, so we think that it's safe and effective in the data support use of metabolic surgery for people with poorly controlled diabetes and a BMI down to 30. If you're Asian, we drop that to 27.5. From my own studies with Dr. Shashank Shah there in Pune, I think it's probably safe down to 25, but the field politically hasn't moved that far yet. But I remember that picture of Dr. Yajnik and Yudkin in Lancet. So my understanding is that for people of South Asian descent, for any given BMI, they have a higher percent body fat than, say, a Caucasian person. For any given percent body fat, they have a higher percentage of that abdominally, viscerally, compared to subcutaneously, where it does more harm. And then in addition, people of South Asian descent tend to have an unlucky assortment of genes in the beta cells that predict less good beta cell function. So wimpy beta cells, along with the body composition that tends to give you insulin resistance, a bad combination. So the average BMI of an Indian or Chinese person with diabetes is about 23 or 4. That's if you look at the peak to the BMI distribution of people with diabetes, it hits its peak at about 23 or 4 for you guys, and about 35 in the United States for Caucasians. A huge difference. So that's why you guys have such a huge epidemic of diabetes in your country, even though you're a lot thinner than we are in the United States. But our degree of obesity is much greater than yours, and yet you have more diabetes per capita and total. Obviously total because you're much bigger, but also per capita.
Okay.
I'm not sure whether the risk is greater for South Asians or East Asians. I've never quite gotten an answer to that, but it's bad for both.
Okay, sir. Yeah. So moving further, our next question is by Dr. Sunil, and his question is, what is the percentage of metabolic surgery which is absolutely required in adolescent age group?
Which is actually required what?
Adolescent age group.
You mean what are the age barriers on metabolic surgery?
Yeah,
I
yes.
think maybe the question is what proportion of adolescent obesity require metabolic surgery? Maybe that's the question. The percentage of metabolic surgeries in adolescent age group, which are
adolescent. I'm sorry.
required.
I wasn't understanding the word adolescent. So Tommy Inge in the United States is the expert there. I wish he were here. I don't know the proportion. It's a very small proportion. Just taking a guess, less than 1%. But it's been clearly shown that metabolic surgery is similarly effective and safe in adolescents as in adults. So if you have adolescents have clearly defined that they're going to be heading toward obesity, and you probably have a higher threshold for doing a big operation than a person that might actually just grow out of it. But if it's clear, if you have a kid with a BMI of 50 or 60, it's probably not worth waiting until they're 40 before you get around to their operation, because they will have had many life years of time to suffer from the consequences. And so it's a small percentage of people who get it, but if you have people who are very heavy when they're very young, surgery can be done. The one situation in which I think there may be some role for gastric banding still, I don't know, some of you may know that a while back, gastric banding, laparoscopic adjustable gastric banding, had gotten to 65% of the entire bariatric surgery market worldwide. And then it just dropped off the face of the earth, and now it's less than 1%. And a much higher percentage of cases are being done to remove old failed bands than to putting them in. So they just didn't have good long-term results at all. But there's one situation in adolescence where I think they may be useful. If you have some kid who's got a huge, terribly obese, but he's only 10, and he hasn't finished growing yet, I'd be a little concerned that if you do something like gastric bypass with a bit of a malabsorptive component that might involve vitamin D, you might be worried that you would compromise his linear growth before he closes his epiphyseal plates. So maybe you would temporize with a gastric band, just kind of hold him in place until he closes epiphyseal plates and achieves his genetic potential for height, and then do something that has the possible risk for some micronutrient deficiencies like vitamin D and calcium. I think that what I just told you would probably be pretty controversial. Other people would disagree.
Dr. Raita, your views? I remember we had a debate in one of our Chellaram International Diabetes Summits on adolescent obesity. Your views on that?
Absolutely. So the only indications for doing bariatric surgery in adolescent age group is that we have ruled out that they don't have any hormonal issues related to their obesity or weight gain. And so also the health issues which they have along with their obesity are risking their life for the present or future. These are the only situations where we can consider an intervention. Otherwise, we have to defer the surgery as much as possible till they reach their bone maturity.
There's also one thing, if you have really severe early onset childhood obesity that seems out of proportion to the family, like the mom and father are not afflicted, there would be an increased possibility that this child might have a monogenic form of obesity, like a melanocortin 4 mutation, or very rarely a leptin or leptin receptor mutation, or several others. These aren't particularly responsive to metabolic surgery. And so if there can be people who are very heavy, very young, and if both parents are that way, you don't worry about this. But if it's a terrible early onset childhood diabetes, obesity, and the family doesn't look that way, think about getting the person genotyped for a rare monogenic form, which may have other forms. So in that situation, you might give them some sort of drug that replaces whatever they're missing. Like if they're missing leptin, you give them leptin. If they got a leptin receptor mutation, you give them a melanocortin-4 agonist.
Our next question is by Dr. N.N. Mantri, sir. And the question is, what are the items of a low-calorie breakfast for a week to make weight loss for a patient of diabetes and hypertension? I think Dr. Geeta would answer this question.
Yeah, sure. When we say a low-calorie breakfast for a diabetic, what's important to understand is the glycemic load of the meal. So very importantly, we look at the food load, the glycemic index of the food is very, very controlled, and at the same time controlled calories. So what are the food items in a practical sense? We look at whole grains. What happens is when you make a atta, for example, let's take a whole grain like wheat. When I make a dalia, the wheat dalia, when I cook it, it doubles up. It has a lot of water, the fiber, the absorption or the conversion of the food into sugar is very, very slow when I use a whole grain as a source of carbohydrate. Similarly, if I convert it into a flour and make a bread out of it or a chapati out of it, I would be using more grains, and at the same time, there'll be a lot of conversion, or the load of the meal will increase. So it's always important to know that when I'm looking at a low calorie for a diabetic hypertensive, look at the whole grains, look at good vegetables, look a combination meal of protein, carbohydrate, fat, and fiber. So the conversion or the glycemic load of the meal is very good. Satiety is better because you have a combination meal. You have good amount of complex carbohydrates, like potato can be replaced instead of grains, sweet potato can be replaced instead of grains. So I think the idea is to tell that the quantity of carbohydrates make more important than looking at the quality of food, because when we say any meal, don't come first. So we can always look at a balanced plate which includes complex carbohydrate, fiber, fat, and protein. So that becomes a low calorie and a good satiating meal which can take the person for next 4 to 5 hours without having food focus. And food which can be eaten more are bread, sandwiches, or when you eat a carb meal, dosas, idlis, sandwiches, you can overload yourself with very high calorie, and then the satiety is very poor. Immediately within 2 hours, your postprandial appetite comes back. So what's important is look at a larger satiety, include fiber, protein, fat in that every meal so that it takes you for a longer period. And definitely the calorie control is always better when you include the 4 food groups in the meal.
Okay. Thank you, ma'am. So next question is for Dr. Unnikrishnan sir. And Dr. Milind Kumar has asked the dose of oral semaglutide. What is the dose of oral semaglutide?
So the dose of oral semaglutide, the starting dose is 3 milligrams daily for a month. And after 3 milligrams daily for a month, you can increase to 7. And this is for type 2 diabetes. Currently, the approval label in India does not support obesity. In my, as far as I know, the India label supports diabetes, but the drug hasn't been marketed yet. So for type 2 diabetes, it's 3 milligrams daily for a month. After that, you can increase to 7 milligrams daily. And after a month, you may increase to 14 milligrams daily. Now, remember the 3 milligrams initial dose of oral semaglutide is only for initiation. It's not for glycemic control. Glycemic control is expected with the 7 milligrams dose. But this is as per the label. We know that in India, because we are thinly built Indians with lots of abdominal obesity, it is likely, I mean, this is very speculative. It's likely that we Indians may respond to lower doses because that has been our experience with liraglutide also. While liraglutide, I used to follow the label and think that 1.2 mg is the dose. Sometimes I see some doctors who started 0.6 mg and I see the patients doing very well. And then I see the 0.6 mg being stopped by some other doctor and then the sugars increasing. So 0.6 mg also seems to work in Indian people. Similarly, one might expect oral semaglutide to be used at a lower dose. But again, the label says 3 mg daily for a month, then 7 mg may increase to 14 mg. Now for obesity, My understanding is that doses of oral semaglutide more than 14 mg may be tried in future trials. And if those trials show benefit, then oral semaglutide might be an option, but oral semaglutide has to be tolerated. There's lots of nausea, there's lots of vomiting, and we are doing the trial also on oral semaglutide right now, the cardiovascular outcomes trial and semaglutide trial. So I'm not going to be at liberty to talk about that aspect. Now, for those of the physicians who are new to the concept of oral semaglutide, it's the first time that an injectable has come in the form of a pill. So in oral semaglutide, you have sodium N-aminocaprylate. Sodium N-aminocaprylate is also called SNAC. So the SNAC, which is combined with semaglutide, it's like a decoy which allows the peptide to slip into the blood and start acting. So you have to take it daily in the morning at the same time and with a full glass of water and not eat for some time. And therefore, it should not be taken twice daily, obviously. And the other thing is there is some amount of variability in this drug. So day-to-day administration, the semaglutide levels change, but once a steady state is reached, only then the drug is expected to work. So these are some of the fine aspects. So we don't have it in India and we don't have clinical experience. Dr. Cummings, could you share your thoughts on oral semaglutide?
Oh, I was going to ask you. I use injectable semaglutide, so I pronounce it differently. I pronounce it the way we used to pronounce exenatide. I use the injectable all the time, but we don't, in my hospital, I work in a veterans hospital, which, they're kind of poor. We don't have access to the oral stuff yet. So I was going to ask you if you had any enough personal experience to compare the oral versus the injectable forms and how you feel. Like you mentioned lots of nausea. Is it more with oral than it is with injectable? I was curious about that.
Well, we can't comment. Yeah, so that's very interesting question. Unfortunately, we can't comment because we have done both the trials. We've done the trial with the injectable and the trial with oral is in progress. So we can't talk about it. And of course, as you know, there is in all these trials, which are randomized placebo-controlled trials, there are both groups. So we won't be able to talk about it. But my impression certainly is that injectable seems to be better at weight loss than oral. And I remember reading about the possibility of a trial getting approval of more than 14 mg oral dose of semaglutide for obesity in people without type 2 diabetes. But I'm not sure that that's going to be tolerated very well by our patients, at least in India. But it's very fascinating, isn't it, how the oral and injectable semaglutide, and now that the peptide is going to come into a pill, it's going to open doors to several other peptides, maybe even insulin in a pill, who knows? So fascinating days ahead.
So I think the important thing the take-home message with semaglutide is that it is a new field. It's kind of a new transforming event in the field of obesity weight loss medications, prescription weight loss medications. All the previous approved medications had weight loss that might be 5 to at best 10%. And this is more like 15% in the average, and a third of the patients or more get more than 20% of weight loss. So it's, 2 or 3 times more effective than anything we've seen before. Pretty well tolerated. You said there's a lot of nausea. In my personal experience, there's some nausea, but it's not as big a deal. It's less side effect prone than Contrave or Qsymia, or definitely Orlistat in my particular experience. So it isn't metabolic surgery, but instead of surgery being 5 or 6 times more effective, it's like 2 times more effective than semaglutide. So it's definitely closing the gap. And the first thing that really is filling the so-called therapeutic gap between diet and exercise and medicines, which traditionally are very non-invasive but not very effective, metabolic surgery, which is very effective but also very invasive. We've long sought something that was in between. It was hoped that some of the endoscopic techniques would fill that gap. At the moment, the only one that really does is Aspire Assist, which is not going to be very marketable because of the gross out factor. That's the tube that sticks out of your stomach and you suck your ingested food out and right after you've eaten it. But semaglutide is kind of in the middle ground between just diet and exercise and metabolic surgery. The injection, by the way, it's worth noting that it's a very simple injection. It's only once a week. It's done with a pen, so you don't have to see this big needle. You hold up this thing, you put it against your skin, and you go click. and it's very small. So you tell me you have more experience with it. In my experience, most of my patients tolerate that part easy, even people with needle phobia. Do you have the same experience?
So again, my experience of injectable semaglutide and oral semaglutide is currently, because of trials, we can't speak about it. Just like to clarify that when I said injectable semaglutide seems to have better weight loss is based on reading of the literature. But I completely agree with you. We do use dulaglutide, which doesn't have any weight loss really to speak of, only minimal weight loss, and has got good glycemic control effects, dulaglutide. And the device is very good, and you can't even see the needle. And of course, it's very expensive in India, and only a small proportion of patients can afford dulaglutide. But those who can afford it, they haven't lost much weight, maybe 1 kilo or 1.5 kilos. But the glycemic control with dulaglutide has been quite good, in my opinion. And there's a cardiovascular protection as well. So if that is anything to go by, I think, and if semaglutide is a big brother of dulaglutide, I think we are in for some very fascinatingly effective treatments. But as you said, it's just closing the gap between physical activity, diet, and bariatric surgery. Bariatric surgery is still the weight loss and the cardiometabolic benefits are still, way ahead of anything which therapeutics can afford at present. But the whole goal of science is to develop therapies which are less invasive and tend to mimic the body's physiology to tackle pathophysiology. From that perspective, I think even nutrition, physical activity, medications which are in tune with pathophysiology will come up in future. There's another question to you, Dr. Cummins, about hypoglycemia with semaglutide. Have you seen that? Hypoglycemia with semaglutide.
No, I haven't. I'm glad you're not leaving semaglutide because I wanted to mention a couple of things about it. In theory, GLP-1 receptors agonists should not be able to cause some hypoglycemia, at least by themselves, because GLP-1 and its agonists don't cause insulin release unless you're hyperglycemic. So some time ago, I wrote the editorial that accompanied the first report of postprandial of terrible hypoglycemia after gastric bypass, rare cases where you get not just dumping syndrome, but people who have to have pancreatectomies to save themselves from hypoglycemia. It's a rare complication in very, very small numbers of gastric bypass people. And the question was, is that because of the huge doses of GLP-1 that are secreted after the operation? And the argument was not apparently, because GLP-1 is well known, doesn't cause insulin secretion when you're hypoglycemic or even normal glycemic. So it just its effect should just shut off as soon as you get close to hypoglycemic. But it can cause hypoglycemia if you're also taking like insulin or sulfonylurea, and then that dose becomes too high once you add semaglutide. Same thing with metformin or SGLT2 and T inhibitor. Those don't cause hypoglycemia by themselves, but they can in combination with another drug that can cause hypoglycemia by making its dose too high. And then I wondered in that New England Journal editorial, it's in animals at least, it's pretty clear that GLP-1 can cause increased beta cell growth. There's evidence of beta cell neoplasia, differentiation, and also reduced apoptosis. So if you have a gastric bypass, for example, and every time you eat, your GLP-1 goes up 30 times higher than it used to be, maybe over time you grow new beta cells and you end up with 3 times as much beta cell mass as you used to, and then maybe you could be at risk for postprandial hypoglycemia. I suppose the same could be argued for semaglutide, but I personally have not seen it as a big risk. I wanted to comment that I know the woman who invented liraglutide, and I asked her I don't know her. I gave a talk next to her at a conference once, and I came up afterward and had a conversation. And I said, why do you suppose semaglutide works so much better than liraglutide at weight loss? And is it because it has a better affinity at the receptor? And the answer was no. In fact, liraglutide is slightly stronger at the GLP-1 receptor. She thinks it's because semaglutide gets past the blood-brain barrier very well, and then has activities on brain centers in appetite control that are more effective than with liraglutide. Now, liraglutide at high dose, 3 milligrams a day, is called Saxenda in our country, and it's approved for weight loss alone, even in the absence of diabetes. But it's more expensive than semaglutide. It doesn't work nearly as well, and it's a daily injection instead of a weekly injection. So I was talking recently to a top scientist at Novo Nordisk, which makes and distributes both products. And I said, is there any reason to use Saxenda for weight loss at all now that semaglutide's around? And he said, nope, should be gone. It should just, so I never use it anymore. I just use semaglutide. In our country also, the Ozempic brand of semaglutide is 1/4 the cost of Wegovy. Wegovy was the stuff that was recently FDA approved on June 6th of 2021 for use in obesity alone and at high doses. But in our hospital, we don't go anywhere near it because it's just too damn expensive. For 2 years of Wegovy, you could have a gastric bypass. It's more than $1,000 a month. So we just used Ozempic brand off-label for obesity. And we feel perfectly safe because Wegovy and Ozempic, they're different brands, but they're made by Novo Nordisk and they're the very same molecule. It's a branding difference. So if Wegovy has been approved and safe, I think Ozempic can be assumed to be approved. So that's what we do. And it costs a quarter the price. What brand do you guys use?
So in India, we have liraglutide, only the Victoza brand. Though liraglutide 3 milligrams is approved in India by the Indian regulator for obesity management, Saxenda, the 3 mg version, isn't available. Of course, I have participated in the scale study of liraglutide in non-diabetic obesity many years back. But in India, if we want to treat obesity with liraglutide, the 3 mg dose is approved, but unfortunately not available. So we have to make do with whatever dose we can give in terms of Victoza or liraglutide. But may I say, because of cost and the limited efficacy in terms of weight loss, we haven't used it that much. And we are all looking forward to semaglutide to come now.
So you're in studies of semaglutide, but you don't have it clinically at either brand? Is that right?
So we don't have 3 mg in India.
No, I'm asking, do you have any semaglutide for clinical use now in India?
No. It is approved.
Oh,
Imminent to be launched. So that's why I had mentioned that since whatever experience we have is in clinical trials, and I'm not at liberty to talk about it. My impression is only from the reading of the literature.
I see. So as a doctor, you can't give it to your patients at the moment. I didn't realize that. I hope that changes. It's really fun. It's really fun to watch your patients lose 15% body weight or 20.
Yes.
You'll enjoy it.
So moving further, so our next question is interesting one. Where is our hunger? Is it in the brain or stomach?
Brain. In the brain.
Anyone else would like to comment?
The stomach produces ghrelin, but the ghrelin acts on the brain.
Okay.
And the stomach and intestines also produce satiation and satiety signals that make you feel full, but they too act in the brain.
Okay, sir. Yeah. Next question is by Dr. Rajay, and the question is: if a 64-year obese person weighing 120 kg and is without any comorbidity like diabetes, blood pressure, or any dyslipidemia, so does he need to manage his weight by exercise, diet, or surgery is the option?
He's 120 kg, so that's like 230 or 40 pounds.
Yeah, and without any comorbidity. So
okay.
What would be the preferred option with diet, exercise, or surgery?
Do you want to assign that to one of us? It kind of covers all of our spaces. Just addressing it from the surgical perspective, it all depends on how tall he is. So 250 pounds is not all that big if you're 6'7".
Yeah.
It's quite big if you're 5'0".
Yeah.
So could the questioner give us a proposed BMI for this hypothetical person? I mean, if it's more than 40, that person would qualify for surgery as an option, although I would personally give them a try with diet and exercise and pills first. I sometimes skip directly to, generally we try behavioral techniques, then medications, and then surgery. That's the kind of conservative thing. As a clinician who practices a lot, if I see a person with BMI 70, I don't usually bother with those other things. I skip right to surgery because I know damn well that no diet, exercise, or medication is going to get them down to a healthy weight. That's why I asked what this guy's BMI was. If it's 36, then we would probably go for conservative measures before we think about surgery. And surgery wouldn't even be indicated because he doesn't have diabetes. But if he's really short and his BMI is 50 something, you're probably wasting your time with anything short of surgery.
Yeah, sure. Moving further, our next question is by Sagar. Can metformin be used to control obesity in diabetes patient? Can we use the metformin to reduce the weight in diabetes patient?
Metformin is usually said to be weight neutral. It doesn't increase your weight, but it doesn't really cause weight loss. Some people anecdotally get a little bit of weight loss, but it's not a very effective weight loss tool.
Okay. And in a non-diabetic patient, it will be the same, neutral?
Yeah, be neutral.
Neutral.
It's a good drug because before we had the newer drugs, just about every diabetes drug increased your weight. Went back in the days when we had insulin and sulfonylureas and thiazolidinediones. So metformin was different in the fact that it promoted glycemic control in the absence of weight gain, and that was good by comparison. I don't think anybody uses it as a weight loss drug in people without diabetes.
Okay. Next question is for Geeta ma'am. How many grams of fruits can be eaten for weight loss in a whole day?
There's nothing like fruits for weight loss. What we look at is a calorie management in weight loss. But a simple recommended dietary allowance for Indians recently in 2020 have given a guideline that a balanced diet needs every day 200 grams of fruits. So what's important to keep in mind, it's a whole fruit, the control of glycemic load, when to eat fruit, how to eat fruit. That's what is important. But a 200 gram of fruit is a must for its benefits of nutrition, which it contributes to our diet.
And next question is for you only by Dr. Om. Any validation of a belief that bhakri of a jawar or bajri is better or more useful in obesity as compared to the chapati or paratha?
Yeah, when it comes to obesity, we emphasize on calorie management. And when we look at calorie, we look at raw grains. So when I just give an example of a whole grain which gets converted to a double or triple the size after it gets cooked, vis-a-vis a grain when it makes into flour gets absolutely in density double, but in quantity or eating it becomes half. So if you look at Indian chapati, fulka, bhakri, jawar size, the sizes vary from household to household, and the bhakri, especially in Maharashtra, what I've seen is almost an atta of 100 grams. So 100 gram raw grain will contribute to 300 calories straight away. We don't realize, we feel we're eating a jawar or a bajra, which is healthy. But in quantitative approach, I think we are exceeding the limit of the carbohydrates, of the calories, and the glycemic load of the meal, which will definitely affect the insulin resistance and the sugar management. So what's important is a quantity control. A 20 gram atta, whatever you eat a bhakri, you eat a jawar, bajra, whole grain, should actually make a lot of sense. 20 to 30 grams of grain in each meal for a good obesity and diabetic management.
Okay. Thank you, ma'am. Next question is by Monica. What are the possible side effects of rapid weight loss which need to be monitored for the patient? The possible effect of a rapid weight loss?
Historically, there's been reports that in people with diabetes and retinopathy, rapid weight loss can make the retinopathy worse. It's particularly true if there's rapid correction of glycemia. But those two sometimes come together. I think it's more the rapid normalization of blood glucose is thought to be possibly could make your retinopathy worse. That has been formally studied. So the best model of rapid weight loss is metabolic surgery. That was formally studied by Carl LaRue at Imperial College London. I guess he was probably in University College Dublin by that time. And they looked at a bunch of people who underwent gastric bypass who had known retinopathy in advance and just did eye exams at 1 year and baseline. And they did not find any evidence that that actually occurred despite the theoretical risk. So from my position as an internist, the only thing I would be worried about with rapid weight loss would be if it was at the cost of malnutrition. So I would defer to the nutrition specialists about that question. I don't know if going too fast is a problem or just going too far is a problem.
Yeah, rapid weight loss may give a very fast muscle loss actually, because fat takes time to go. And sarcopenia is the first impact of rapid weight loss. Weight loss due to starvation, a very low calorie diet can give a lot of muscle loss. And that's why I think these weight loss are very for short duration. you're hurting the metabolism, you're missing out the muscle fat ratio. The goal of weight loss, I think, is missing out when we do a rapid weight loss. And definitely, as Dr. Cummings saying, other impact of metabolic changes in the body are the side effect of it.
We have
But,
seen patients developing gallstones and landing
yeah.
up with cholecystitis with rapid weight loss.
That's definitely true. I forgot about that. I thought on the point of sarcopenia, it's definitely true with big weight loss, you lose fat mostly, but you lose muscle too. So like with metabolic surgery, there is a loss of lean body mass that's found. But I used to give the lecture in our medical school on starvation as a model of fuel utilization. So what's the situation with somebody who just stops eating permanently? And I thought you clean out your sugar first from your bloodstream in a few hours, and then you clean out your glycogen in your liver, and then you go for fat. And it's only very sort of stingily at the end that the body will turn to gluconeogenesis from muscle and muscle breakdown. And it uses ketones and the beginning of gluconeogenesis from the liver, from the kidney as well as the liver, to try it's best to hold off to the very end anything sacrificing muscle. Am I wrong? And does going too fast hit the muscle disproportionately than losing the same amount of weight slower? I didn't know that.
And what happens, Dr. Cummings, is if you are starving for more than 12 to 14 hours, then I think the fat, the calories are used from fat as a source of energy. But if the calorie control is there and the feeding is not appropriate, like carbohydrate protein fat ratio, the substrate utilization for energy changes. Body shifts to lean body mass for your energy, especially when you do a high intensity exercises, like Dr. Malhar said, that when your body shifts to a very high VO2 max while you're exercising, the body needs more of muscle glycogen to work out. If you do not have adequate muscles, then the HIIT exercises won't give you the benefit of that fat and muscle gain and loss which we are looking at. It's mostly a calorie burning which happens. And then you lose a lot of muscles while you're doing this HIIT. So similar application applies when you're doing a calorie control, and how you're doing is more important. Intermittent fasting serves after 14 hours, body goes to fat as a source of energy. But if you're just starving and on a hypocaloric diet, as the VO2 of your body keeps changing with your metabolism, I think the shift is always there to use muscle as a source of substrate or muscle glycogen. In absence of muscle glycogen, body uses muscles, lean body mass for energy. And I think this regulation of substrate utilization of body is absolutely depending on your metabolism and your muscle weight fat ratio and your VO2 of your activity.
And would you mitigate those consequences if you took a really high protein diet while you're losing weight?
If you have a very high protein diet, what happens is you're not sparing proteins, you're actually using proteins for energy. So you have to have a balance between non-protein and a protein calorie. So definitely a keto diet will look only if you are looking first 2 days of washout, and then the body goes to ketosis, and then the body uses fat as a source of energy. Otherwise, today's diet, what we use is modified keto diets, which do have 20 to 30% of carbohydrates. They may or may not give us the goal of muscle and fat benefit, which we are looking at. So high protein generally doesn't do a muscle sparing action. I mean, it gets used for energy most of the times.
Okay, thanks.
Thank you, ma'am. Next question is by Santosh Datar. What is the correlation between sleep deprivation and obesity?
I have some insight into that, but I don't want to monopolize the conversation. Okay. There was a big publication at the level of New England Journal a while back. Susan Van Cauter, I think, is the name. It was just looking at the relationship between habitual hours of sleep per night and BMI, and it's a U-shaped curve. So if you do sleep 10 or 12 hours a day, that's associated with being heavy. That kind of makes sense because you basically, during the time you're sleeping, you're not moving around at all. So you're not exercising even just in terms of moving. But as you sleep less and less, BMI also goes up. The nadir, the place where people are associated with the lowest BMI, is about 7.5 hours of sleep at night. And then less or more than that, steadily is associated with increasing levels of BMI. The mechanism of that in the, why does sleep deprivation why is it associated with high BMI? That's not fully known, at least it wasn't known at the time I reviewed that paper for the New England Journal, but it was found that for a given BMI, if a person has low sleep habits, they have disproportionately high ghrelin and low leptin compared to other people with the same BMI and the same fat mass who sleep more. Mechanism unknown, but a combination of high ghrelin and low leptin would promote body weight gain. So it's thought that chronic sleep deprivation is bad for body weight, promotes weight gain, as does excessive sleep. So based on these findings, you would want to try to sleep 7.5 hours a night, if from the BMI perspective.
Dr. Unnikrishnan, yeah, would you like to add any point?
Yeah, so there was a question on the mTOR. There was a question on the mTOR earlier, and I did talk about how the mTOR has an effect on inhibiting of mTOR has an effect on lifespan, and inhibition of the mTOR by calorie restriction has an effect on lifespan. Now, some of these studies are also showing that this effect of calorie restriction on inhibition of mTOR, which might prolong the lifespan, is also determined partly by the circadian clock in the body. So, every every part of the body, the liver has its own clock, and the pancreas has its own clock. So because of this, the importance of a circadian clock is paramount in determining the effects of calorie restriction. That's how this time restricted meal comes, etc., etc. So the clock genes the clock gene discovery was given the Nobel Prize, and also sleep deprivation is going to have an effect on the circadian rhythm and therefore impact obesity and type 2 diabetes in many ways. One is, like Dr. Cummings very elegantly pointed out, the effect on BMI. The second is simply the reason for sleep deprivation, which could be because of stress, which could be because of excess watching of the mobile phone or devices. All these things increase the cortisol, which in turn drives an adrenaline, which in turn drives hunger and also increases the heart rate. So there are multiple ways in which sleep deprivation induces bad effects on obesity and cardiometabolic risk. And in some ways, there is a social jet lag, just like we get jet lag when we travel from, say, US to India or India to US. By taking caffeine at night or the blue light of the mobile screen, these induce a state of social jet lag, which also has an impact on cardiometabolic health. Because if you get stressed out at night and if you pick up a snack and eat it at night, the brain is telling you it's time to go to sleep, but the liver and pancreas are telling you that it's time to dispose of the glucose load. So this dyssynchrony between these two signals may be a critical driver of obesity and cardiometabolic risk. Just some random thoughts.
Yeah.
There is another story about melanocorticotropin receptor hormone, and that is driven by MC4R gene. And definitely the impact of sleeplessness or the time management of sleep can drive more snacking tendency because of this MC4R genotype variations, or it may be a poor lifestyle circadian rhythm management. So that also contributes to your insulin resistance and other NCDs.
One of the smartest guys that I know closely personally in body weight regulation research is Lee Kaplan at Harvard. And he has a quick way of saying that among the societal contributors to obesity, that have caused the pandemic, the electric light bulb was probably the biggest contributor, because before we could illuminate our houses, we went to sleep at night. Now we stay up all night, or people stay up later than they should or would if they didn't have any light to illuminate themselves.
Okay, thank you all the panelists. So as there is no further question, I think we can conclude our session here, as we don't want to sleep deprive Dr. Cummings as well, because I think it is a late night there in Seattle.
Yeah, 12:40 a.m.
Yeah, so
that's okay. I'm actually very impressed with how well you stayed on time for this whole program.
Yeah, so I think we can conclude then. So thank you very much, Dr. Cumming sir, for taking out the time from your busy schedule and joining this CME, live CME on obesity management. You have really shared your extensive knowledge with us. And simultaneously, I would personally like to thank other panelists also, those who have shared their thoughts, their studies, and various points regarding the obesity and its management. I would also like to thank the DigiShield and our sponsor and all the participants who have joined this CME in the obesity management. So I would like to conclude this, and I would like to thank everyone for making this CME a successful one. Yeah, thank you, sir.
We would also like to thank Dr. N.N. Mantri, sir, our Maharashtra Medical Council observer, for staying here, sir. It was glad to see you. And I would also like to thank all our Chellaram Diabetes Institute team, Ms. Shraddha Pandit, sir, for his inaugural speech. And thank you so much, Professor Cummings. It was pleasure to meet you virtually. And
My pleasure.
Dr. Unnikrishnan, sir, would agree with me that we have conferences which we conduct in India, International Diabetes Summit. So as the borders open and the COVID comes down, we would be happy to see you personally face to face during our conferences.
Yes.
That'd be great. I miss the face-to-face component a lot since COVID.
And I would also like to thank Ashutosh for leading this show, and it was a good job. Thank you, Ashutosh.
Yeah, thank you, ma'am. Yes, thank you.
Thank you, Ashutosh.
Yeah, thank you, sir. Yeah.
Thank you.
Thanks.
Flattered and honored by the invitation to speak.
Yes. Okay.
And thank you for the
Unnikrishnan,
education
sir.
from the other
Thank you,
speakers.
Raite, sir. Thank you, ma'am. Geeta, ma'am.
Thank you.
Thank you.
Thank you. Well done, Dr. Ashutosh and team, and Dr. Raite, Shraddha. All of you did a wonderful job. And
Thank you,
Dr.
sir.
Malhar spoke well, Dr. Geeta spoke well, Dr. Veda spoke well. Dr. Pandit spoke very nicely. And of course, Dr. Mantri, we are privileged to have Dr. Mantri with us. So good. Bye for now.
Yes. Thank you. Thank you.
Piyush, it is fine if we leave now, na? Piyush.